First order of business is roll call. So if I may check in with my colleagues. Siobhan Martin, was that your voice I heard?
Yes, I'm here. Thanks, Dawn.
Thank you. Greg Clauser, I believe I see you on camera.
Yes.
Are you here? Thank you. Cheeky Flowers. I don't hear Cheeky. We'll give her another moment. Andrea Foltz.
Here.
Thank you. Sean Parkman.
Here.
Thank you. Kimberly Hendricks. Not hearing Kimberly Hendricks, but I am hearing someone else off mute. Let's see. Emily Wong, please.
Yes, I'm here.
Good morning, Emily.
Good morning.
Rep Nose, I believe I see you on
Yep, here and present.
camera. Good morning. Thanks for joining us.
Yep.
Go back up to Chicky. Has Chicky had a chance to join us?
Good morning. I am here on by video and audio.
Perfect. Thanks, Chicky. Good morning. And Kimberly Hendricks. Has anyone heard from Kimberly? Is she excused today? Or are we anticipating her participation this morning?
I can check in with Kimberly. Dawn, this is Ollie.
Thank you. All right. Without Kimberly, though, we are at quorum, so we can proceed. Am I correct? All right. The next order of business, please, is the review of the minutes for our last meeting, which was in May. My colleagues, have you had a chance to review the minutes?
So this is Siobhan. So I've reviewed the minutes and I asked for, I believe that Sean Parkman was not present and at our May meeting. And so Rose has sent us an updated version of the minutes to let us know that Sean was excused. And so with that update, I would make a motion that we approve the minutes.
And I can second that, Clauser.
Thank you. And with that, I believe we can transition to the next phase. May I hand it over for a brief moment, Siobhan or Ali?
Sure, I'm happy to lead until you're able to again, Dawn. So it looks like the first report of the day and discussion is going to be about care and case management. And we have Mary Kay O'Neill, Emery Chen, and Ruby Castaneda here to lead that discussion. So I'm going to hand it over to you all.
Thank you, Siobhan. So this is Emery Chen with Mercer. We are kicking, well, I guess this is actually maybe step 2 of the medical RFP. We did discuss the RFP previously, but we're really kind of starting to dive into some of the topics with the RFP, starting with this meeting and in future meetings and with the proposed retreat later in fall. So what we want to do is actually, there's a lot of different topics that we want to discuss on RFP. So we've broken them up into sections. And what we want to do is we want to make sure that everyone's kind of understanding and using the same language and, generally agrees to what we're talking about for the various sections. So in terms of care and case management, those terms they're very specific, but they may not mean the same thing to everyone. I know when I've been discussing with other people, we may be coming from it from different views or like being the how they're being discussed and what those processes are actually, very specific in a medical plan management case versus, what maybe just discussions with the board and other members. And so what we want to do is to actually dive deeply into care and case management to kind of really lay it out for the board members so everyone can be educated and get your essentially agreement or potential questions or disagreements on where what Mercer might consider best in class, and where care and case management might be for the next PEB health plans. So we wanted to just kind of lay it out, give you like descriptions, understanding, and case studies on why it's important, and make sure that everyone understands why we're talking about it and where we potentially could be headed for the types of questions that we might ask in the RFP. And to that end, Dr. O'Neill is here to present that. But before that, I think we wanted to turn it over to Ruby to actually provide a few comments about the RFP and the RFP process. Ruby.
Thanks, Emery. So hello, board members. My name is Ruby Castañeda. I last had made comments previously. I am the lead staff for the PEB's medical pharmacy RFP. And I just wanted to do a little reminder of the importance of the integrity of the RFP, ensuring that if board members or internal staff, including consultants, if they get current vendors requesting information or just sending them like a sales pitch, we want to ensure that we just have a blanketed statement indicating thank you for your inquiry. And currently right now we're in the design phase and cannot really comment on the RFP since we have certain statutes and guidelines that really guide that RFP process, and we want to ensure the integrity of the process is not I can't think of the word, compromised. There we go. So I have a blanketed statement that I have shared with Mercer. If board members or staff want to utilize that, I'm more than happy to share that. But that's all what I really wanted to state, was just that little reminder. Thank you.
Yep. Thank you, Ruby. And with that, I think we'll turn it over to Dr. O'Neill to reintroduce herself and to provide the presentation. Thanks.
Uh-oh, MKO, I think you're on mute.
Yeah.
That's my most efficient mode, mute. Anyway, thanks, Emery, and thanks for having me here today. And I just want to start by saying that, in our discussions about this presentation that I'll be giving today, the intent really is to kind of lay the groundwork about what care and case management is. And in particular, of course, the important thing is how it aligns with the values and objectives of the PEBB board and how services are delivered to members. So I am very comfortable with anybody making comments or asking questions at any point during this conversation. So it's not valuable just to have me talking on if it's not working for people here at the board. But I wanted to give a little bit about my background, and maybe everybody saw this at some point in time, but in my career, I went to med school, practiced medicine for 13 years, ran a large department in a multi-specialty hospital organization in Seattle. So I have a lot of hands-on experience taking care of patients and what that means. I also have experience in working within the healthcare delivery world, and how do you organize that, and how do you support people providing care. And I'm a rehab doctor, so this was very complex. And so virtually all our patients needed some kind of case management. We had a 24-bed unit in the hospital, so I know inpatient medicine, outpatient medicine, compliance. I took care of injured workers. I know a lot about regulations and all of those kinds of things. And after doing that for a while, 13 years, I transitioned to being a medical director for the Uniform Medical Plan, a part of Washington PEBB. So I was starting in on a, what you might call population management view of the world, looking at benefits, looking at the people we were serving, looking at how we could optimize both our plan design as well as delivery of services, and really understanding what was valuable to people in the context of their health and their life. And after doing that for a while, I spent a decade in leadership roles, chief medical officer roles in health plans. And so I did that for Cigna, I did that for Regents, and I did that for Coordinated Care, which is a managed Medicaid program in Washington. So very deep dive in education into how health plans work, what kind of information flows to health plans, how services are organized, how what the options are in engagement with members. And which is, as I think many of the discussions I've been privy to in earlier board meetings, is one of the big issues. How do we position services in a way that people can find them, use them, and trust them, and have them be practical for them? And then now for 8.5 years, I've been working at Mercer, consulting with different healthcare purchasers about their benefits, and to some degree, the health and safety in the context of work people do for our different clients. So I just wanted to give you that background because my comments come a lot from my experience and having worked within these systems. And so hopefully one of the things I can do as we go through this larger process is help with viewpoints like what can we ask for? What is the most effective way to ask a carrier to do, pardon me, to do this kind of work? How can we get information from them about what's actually going on and those kinds of things? Because I've sat at those different seats at the table, and so I think, I kind of, like, if you will, know the language of the different sectors of healthcare. So anyway, I just wanted to put that out there before I launched in on the slides. And once again, please let me know if you have questions or comments or think something's being missed or not stated correctly. So we can go ahead to the next slide then. So I was asked to talk about care and case management. And so I know that the board has been through this process recently with my colleagues doing a deep dive into case management. We'll share a little bit of information from that with the current carriers. And case management is a quite well-defined process. When health plans are accredited by entities like NCQA or URAC, there's a whole raft of rules and standards and stuff around case management that they're looked at. How is it staffed? What's the turnaround time? What's the engagement rate? What's the training? What's the, all these kinds of things. But when we get into care coordination and care management, these are almost more like concepts than they are specific care delivery. So I thought it would be useful for us to talk about that and because that makes a difference as we proceed with what we want to have happen for PEBB membership and how we ask questions and what we are looking for in the RFP that's to come. So, so case management, as I'm going to start at the bottom and work up, since it's the most precise. It's generally what we think about for the systems of the carrier systems, looking at resources for people that are in fairly complex episodes of medical care, right? So if you look at the case management list, you'll see people who are entering into care for cancer. You'll see, complex obstetrical cases with babies in the NICU. You'll see people who've had serious accidents. You'll see people who had serious medical complications and things like that. So this hopefully is a very small portion of your group, but they are people who need additional care to make sure that the right thing is happening for them, that they understand how to get through the episode, both themselves and their families, and that they understand how benefits work for them, because obviously the situation itself is overwhelming. And so suddenly expecting somebody to have an advanced degree in benefits is probably unrealistic, or even if they do, they still need the help, right? care coordination is a concept that's been around for a while, and there is an element of care coordination within case management, which is, things like, well, what else do you need to get the best possible outcomes? What do you need? And one of the care coordination pieces that often is emphasized in case management is transition planning. So somebody's been in the ICU, they're going to the regular part of the hospital. Somebody's been in the hospital, they need to either go home or to a skilled nursing facility. How does that happen? What equipment do they need? Which providers do they need? Maybe somebody's been in a complex episode around behavioral health. What is their ongoing support post-discharge? All of these kinds of things. Or somebody has a medical issue, we need to get either caregiver support, behavioral health support, something else, and it's a very hard thing for people to navigate. Very, very tricky. And so care coordination is designed to do that kind of work. And then care management to me is much more of a concept. And this happens even, in the setting of care delivery in a physician's office or whatever, which is to think about how the person is interacting with this big system of healthcare to get their health needs met. And I know that the board's been quite educated on things like social determinants of health. So care management can include those kinds of concerns. It can include the fact that, me as a rehab doctor, I could see somebody, I knew what they needed. They needed to have a fairly intense sequence of physical therapy appointments to really help them get past the issues that they're having for whatever musculoskeletal reason or neurologic reason. But if I am not aware of and don't solve the problem of the fact that they can't go to PT because they have childcare needs or transportation needs, all my best clinical thinking is basically useless, right? So there's a lot of room for care management across everything that we do. It has, and in the carrier world, it can be, how customer service works. Do they hear something that tells them this person's maybe asking about a primary care physician, but they actually have these other problems that will be barriers to them getting the care that they need. So in some ways, I think of care management as trying with all the interactions with members of standing in the member's shoes. What would it take to make the right thing happen? So maybe not everybody agrees with that definition, but over my career and sitting at the different seats of the table, that's how I come to think about it. It is it's the member focused approach, bigger than whatever the diagnosis might appear to be. That would be the physician bias on that one or whatever. So
I just want to make sure you see that Sean has his hand raised.
Okay. Hi, Sean.
Hi. Thanks for this overview. I just wanted to bring up a topic particularly around care coordination that we don't necessarily need to dive into. I mean, we don't need to dive into it right this minute, but it's just part of the mix that I haven't always heard discussed openly at PEBB related to case management and this kind of world. And that's the topic of hospice care referrals. So, there's a lot of I'm going to tell you something that but I'm just putting the topic out there, right? Which is there's a lot of information, a lot of evidence out there that there are great benefits for being referred to hospice care for both psychosocial effects as well as family support, and there's an equity disjoint uh, different people are referred to hospice at different rates. It's not equal. And so some people are not referred to it, and it's very difficult to speak of in the context of health insurance purchasers like this, like these kinds of boards, because there's this kind of uneasy bias in I think these kinds of settings where it's like if you're talking about um, preparing or offering someone services around their death, it's like we failed. It's like well, we didn't cure them, so that like we failed, and so now we're just trying to, some sort of bias like this. Now we're just trying to get rid of them or something like that, and it's just like no, it's actually a service that's really serious and can really benefit people. But sometimes the medical system really is reluctant to start that discussion, especially in these case management situations, because it's just like, oh, we're just going to fight to the end and when we won't fail you and this sort of thing, kind of proposing death as if it's a failure. And so I just kind of wanted to put that out there because that's a lot to do with care coordination,
Yeah.
is to be sure that that's built in as an option, that people are well informed and it's not proposed as like, well, if you want to give up, I guess there's this, and it's not like that. And then there's a lot of things that need to happen that are quite um detailed to carefully transition this person when the if and when the time is right to that kind of care, like discharging and where do they go, and so they're not missed and all this stuff. So I just kind of wanted to mention it because we are talking about uh, medically complex situations, and sometimes that means that someone's not cured. That that's the for their family, for themselves, that's the best choice for them, and we don't want to miss that and like have that as a totally different system and be like, well,
Yeah.
at that point we're out, that sort of thing. So
Keith brought up a point I was going to say too about there's this whole concept of palliative care. And it's a little different than hospice because hospice is technically end of life care, but palliative care is really an approach that you can take, and it's really in this care management mindset, if you will, of asking people how they want to proceed with different conditions. And being a rehab doctor, I did some cancer care rehab, but I also took care of people with things like ALS, right? And conditions like that. And you can have very valuable conversations about what's important to you. How do you want this to go? What resources or what kinds of things do you absolutely want to avoid? And those kinds of things. And you're right, the physician community is not always, we have a bias for action as a profession, which is not always in service to our patients, right? But we also have data from palliative care and hospice care that people that get entered in it earlier and whose wishes are understood and they and their family are supported actually have longer survival times. It's probably because we're not doing stuff that's not going to help them and may actually make their time more miserable, actually. You can look from the payer side, maybe you can save some money on some of those services, but the actual thing is you're listening to and able to serve the person you're trying to care for. So I think that this is very much in this area, and a challenge, as you have identified. But I think that needs to be part of our thinking going forward, for sure. So
yeah, and I appreciate bringing up palliative care, and yeah, I think it's just worth having the topics.
yes,
Palliative care and hospice care are quite different, although people often refer to them together. Um, and I think for various reasons, the medical system sometimes is more comfortable talking about palliative care, but I think it's important not to lose sight of both. They're both valuable.
yes,
They have different lanes.
yes,
And it's important, I think, to understand. So when we're talking about the system of care coordination, it's important to have the two things separate, and there's not like one arrow that goes to like hospice / palliative, because
right,
they're very different. So yeah,
right, absolutely,
yeah.
absolutely.
Thank you.
Thank you. A lot of material here. So So what I was thinking of, and I was talking with the Mercer team, and we've had some discussion with staff as well, is how are these topics and the approach to these topics and the understanding of these topics will impact the goals of the RFP process in terms of getting the kind of care and services to PEB members. And so obviously, even for the likes of me, who I just described how many seats at the table I've sat at, if I am engaging in pursuing medical care, I can still hit roadblocks and want to tear my hair out. So far, I haven't had to, engage in particularly complex episodes of care, but if it's hard for me, it's got to be hard for most people. So when we're thinking about care delivery, and we can see all these great things that different organizations do on paper, I think this care delivery is the way of asking questions about, and how do you make that actually happen for people? How hard is it for people to navigate what you're putting out there? So, this, we have spent a lot of time, I think, in my career over these years of taking a kind of educationalist approach to putting a lot of information out there. But, sometimes as people are entering into an episode of care, big or small, a big amount of information about a topic that they're unfamiliar with may not actually be as useful and impactful. So trying to give resources to people where they learn what they need to learn in a way that is accessible to them, that they can understand and trust, and then to try to coordinate all the craziness of, if my primary care doc says I need to go see the endocrinologist and all of this, and how does that happen, and which one should I see, and how does the information get back, and all of that kind of stuff. I mean, we just need to be thoughtful about how we're asking those questions and how those things are made to happen. And so, and it needs to be easy for people to understand how to access these resources, and it needs to be put out there in a manner where they can find the resources when they need them, not just during open enrollment. That there is, an engagement that works for the person in terms of time, accessibility, content, impact, and trust. And that, once again, like I always say, that people with complex healthcare needs often seem to be expected to have this advanced degree in health systems, which, and some people I knew, like I took care of patients that had kids with cerebral palsy and muscular dystrophy and all these kinds of things, who had unbelievably complex care needs. And some of my patients probably knew things better than I did because they'd been navigating for so long. But that piece of it shouldn't be the big challenge, right? The health should be the big challenge. So trying to think very much about the member experience. And then I think, as has been brought up multiple times, and as is a clear priority for PEB, if we put things together that are trying to meet the care delivery and member experiences needs, are they working the same for all the different groups within PEB? Is it working for people with different ethnicity or gender or rural, urban? That's been a big thing that I've been hearing from you guys for a long time. So do we have the data? And well, lean on Emery for this one. But do we have the data to be able to tease out and tell, is this as useful to somebody in Burns as it is in Portland? Is it as useful to somebody from different cultural backgrounds? And what are we seeing around engagement rates and ongoing impact of these programs? And then there's the payment reform, and which is another thing that gets tricky when we talk about this intersection of cost and quality. That I think everybody that's been sitting in the systems part of this thinks about, well, if we get people to good quality care, it's often the most cost effective and the biggest ROI. True, but then we can't make it so that that approach fails, because in order to get there, the individual member has to navigate all of this information and land in the right place. So if we are going down the payment reform pathway, part of the questions we need to ask and get answers for is how's that, my favorite consulting question, how's that supposed to work? How's it supposed to work for the member? What do they know? How do they make decisions? What can they see from where they sit? And how do they find their way to this quality, right? So if these were simple questions to solve, by the way, I probably would be on some book tour or something like that. But anyway, I mean, these aren't easy, but these are the questions, right? I think these are the questions. So I don't know if anybody has commentary on that, but if not, we can go to the next slide. So this is just some of the case management impact that we are looking for. And I don't know if this is in any particular order, right? But if people can engage in something, and we all hear stories about case management cases that go unbelievably well, right? And so that there are times where somebody is going through something, a connection is made between case management and the carriers and the individual or their family. And they are walked through these really difficult episodes, and people will say things like, I can't imagine going through this without the help of my case manager. They were wonderful. They asked me all these right questions. They anticipated my needs. They made this so much better and less scary and all of this kind of stuff, which is the ultimate of what we're looking for from case management. But I think that we need to look at the thing that from a systems perspective is always part of the disappointment with these is that we don't engage as many people as we'd like. We miss people. I think those are those reports you see. We have the opportunity to help a lot more people than get helped. And some of the barriers may be, some of the lack of sensitivity to the needs of different groups of people. So the diversity, equity, and inclusion lens. Some of it may be where the information is placed. Some of it may be that some people have had the experience that if their health plan calls, it's not helpful, it's a waste of time or it's not good news. Well, that's a trust issue, right? And with the system in general. And sometimes I think that there is a conflict between what the plan is trying to do and what a person might be hearing from their physician. And to me, having been a chief medical officer of health plans before, I think that's a miss on the health plan part about how they're managing their networks. So there are lots of opportunities to look at this in ways to make sure that the good stuff that they do know how to do is happening for the people who need it. So, and then the bottom line is back to what the point I just made. I think getting the right care done as early as possible, understanding when somebody's entering into a complex episode, those are the things that bring value to the individual, and value, you can save a lot of wasted time and energy and anxiety on the part of the person and their family. So hopefully it's making some sense. I'm getting some nods. So I know that you recently went through an audit of the case management with the current carriers, and my colleagues Cindy Crozier and Christy Ewing were part of that. I was not a part of the individual review of these carriers, but these are some vignettes that we saw. And I don't know, Emery, is Christy or Cindy on here?
Christy's on. I don't think Cindy's on.
Okay.
I'm here, Dr. Mary Kay.
Hey, Christy.
Hi.
I don't know if you want to do that. I feel a little like, I don't want to, this is your work. I don't know if you want to talk a little bit about these vignettes or if you feel you want me to do it or however you'd like to proceed.
I think this first one is the one that was from the assessment that I was involved in. So I'm happy to review this one.
Why don't you do that? Yeah, thank you.
Okay, yes, and then please add in. So this came from our behavioral health assessment that was completed. And in this example, so this was a member, 15 years old, non-binary, had a primary diagnosis of depression, and then the secondary diagnoses. And part of the assessment was really, you know, getting we kind of get a report from the carrier on, exactly what happened. It's a collaborative team that shares an overview of the case, how case management was handled, what the different outreaches look like, the timing of those, and ultimately what the outcome was. And so really, for best in class, what we noticed in this example is that it's really important to have a designated place in the electronic health records where there's a preferred pronoun. And it really needed to be, kind of in the same place for everyone using the EHR, and then also top of mind with kind of a reminder. So that stood out. Really having this seamless care transition piece where, really having case managers having an opt-in approach instead of, I guess, sometimes what we hear is there's oh, it sounds like you're doing really good. You have your appointment coming up 6 weeks from now. You just reach out to us if you need something. And so the opposite of that is really having an opt-in approach that is just assuming that person is going to want and benefit from support. And, opposite of that would be, it sounds like you're doing really well right now. You have your next appointment in 6 weeks. And, if okay with you, I would love to continue to check in with you over these next 6 weeks and make sure that your care and you're doing well before that next appointment. Additionally, with this case, just having additional support for parents and family members and checking in, doing some screenings and recognizing that a lot of times these, if it's impacting one person in the family, it obviously has a broader impact to the broader family. Coordination with the inpatient facility. So especially in this case of a minor, having better coordination with an inpatient facility so that you can get the ROI, so the release of information before the minor is being discharged so that there is really good coordinated care with the parents. And then again, that post-discharge outreach, really recognizing it's important to have a licensed behavioral health clinician that is doing that post-discharge outreach. Again, because through that licensure process and obviously the experience of being a licensed clinician, there's other things that might come up that you'll notice a family member might say or the patient might say that is going to need more of a clinical focus and that type of background in order to direct that patient to the right care versus it just being kind of a care coordinator that doesn't have that extensive clinical experience.
Yeah, Christy, I think that's such an important point because it is the sort of historic bias of health plans to think about benefits and interaction in a very episodic way. And I know from clinical experience, both as a chief medical officer of a health plan and as well as a clinician, that if you are just oriented to like the hospitalization part of the episode, particularly, well, very rarely are things like neat and tidy and all tied in a bow, even with something like an orthopedic procedure at the day of discharge, right? There's more needs. There's transition to dealing with whatever you're dealing with in an outpatient setting, which can be more challenging. So really having a clinical and an engagement strategy for the person to make sure that whatever intense care like a hospitalization, that the value of that continues to transition as people go into the next phase of their care, and particularly with, well, it's like I said, it's there's a lot of situations where you need that, but behavioral health issues don't just go away at discharge, by the way, just my clinical experience and opinion. And so that ongoing clinical need and making sure people land somewhere for their outpatient care that's meaningful and working for them is how you get the value out of the more intensive part of the treatment plan. So,
Don, you had a comment or question?
Yes. Dr. Mary Kay, I appreciate your noting there that we as physicians, we have a tendency to center ourselves in our thinking and have to do pretty hard work to re-center the conversation around the patient. There is a puppy barking here. Is that coming through? It is, right?
that's all right.
Sorry. What I wanted to note was specifically that actually life goes on very much outside of the hospital and outside of those things. And that is where our thinking needs to be centered. And the way that you've been describing this is a good reminder to us that as payers, as clinicians, as clinical teams, when we center ourselves, we're talking about the intensive and the hospital centered and the costly in dollars parts of care. And that isn't where the vast majority of care and experience and patient needs are happening. So care coordination, case management, and all the more intensive ways that we need to work to be sure that people are getting what they need in their lives and in their families and living the lives they want to be living takes work to convince us over and over, docs, that we're not the center, that it needs to continue to be centered outside of us and out in the community. So I appreciate that observation. And I see that Sean has his hand up. Before I hand it off to Sean, I'm going to acknowledge that I'm juggling some health issues in my family this morning. And so I am going to step back for the rest of this meeting and ask Siobhan to lead the rest of this meeting. I am here and participating, but I'm going to ask her to lead. So thank you very much for the work. I'm here. Thank you, Siobhan. And Sean, I'll hand it off to you.
All the best, Don. Sean?
Yeah, just another topic to just kind of put in the hopper for thinking about our RFP, best practices, that sort of thing. We're talking about case management, and we're talking about behavioral health in particular, case management. So I was just curious, maybe a couple sentences from Christy, just because you just did this dive into this, and it's all my question's also relevant to people who have chronic diseases, who are in a complex medical situation, which is the topic that we're talking about. But I'm just curious on the behavioral health side, which would not be isolated to just things that are technically diagnosed as depression or whatever. I'm just wondering, where did you see evidence of referrals or care coordination to outpatient stuff that engaged mindfulness-based stress reduction, that kind of field that sort of has increasing evidence over the years of just being kind of generally helpful for like pain management, chronic disease management, psychosocial outcomes related to, kind of scary diagnoses, that sort of thing. Just curious what you saw in our experience out there.
So I did not see specific referrals to MBSR, which is that mindfulness-based stress reduction. And Sean, you're right. I'm actually certified in MBSR and have been part of a health system teaching MBSR to folks with chronic pain. And so we did not see that specifically in the assessment that we did, but we looked at a small group of cases. It is a best practice, right, to refer to programs like that. We did see some referrals to community-based organizations, again, depending on what that, patient's needs were, and, really assisting and coordinating that care to the case management did a good job in one of the cases particular that's coming to mind, where the patient was referred to community-based organization, and they did assist in getting coordinated and did a follow-up. So there was that broader look, but I do think, as you stated, recognizing that there are these evidence-based programs that can be referred to, and a lot of times they might not be embedded in the health system, or you might be, might not in the provider directory, right? You're not going to find necessarily MBSR, but recognizing that there are these other services that can be beneficial offered within the community. So I think it's important to know that in the RFP of asking those questions, and really, and then I think I'll just say as a second follow-up is making sure that those dots are being connected and people are being referred, and connecting with those programs.
I think, Sean, one of your points, first of all, the most common disease or the biggest disease burden from our data right now in the United States, maybe second to obesity, is mental health disorders, right? I mean, it's common. It's not uncommon. We also know that there are risks around chronic conditions. So, for example, when we have quality metrics about taking care of somebody with diabetes, we have screen for hypertension, screen for kidney disease, screen for neuropathy, screen, because all these things that we know that are consequences of having diabetes. But the incidence of depression and diabetes is also quite high. The incidence of new onset depression following a heart attack is quite high, but we don't have in our sort of quality metric that's so medically based the automatic screen for this thing that happens frequently and makes a huge difference to somebody's ability to comply with other treatment protocols and all this other kind of stuff. So I think it needs to be in the machinery and in the system. I will say I have talked to a number of primary care physicians in the context of organizing care and accountable care organizations and different things like that, who have admitted to me that they don't ask behavioral questions. They said, because if my patient tells me they have the problem, I don't know where to send them. And so one of the connect the dots that I think Cindy was so wise to bring up is that we need to put those resources not just in a case manager that might interact with 5 to 7% of the population when we know 30% of the population has the issue, or more maybe, but in the hands of the network physicians who are caring for them. So it needs to be easy for them to go through the process of identifying what's really going on and connecting people to care. So I'm a sort of a systems thinker, and I think that connected. My two favorite things are to ask, how's that supposed to work? And my next is, how can we connect the dots? So, and I think those are the things that have been standing in the way of the level of effectiveness of these efforts. So as Cindy pointed out, there's a lot of good efforts being made in the case management world, but it's just not getting us where we need it to go, either within the context of a given case or how many people they actually end up engaging. So super important issues.
Want to also recognize Emily wants to chime in too.
Oh, okay, great.
Yeah, this has really been helpful, this whole conversation. And I'm just going to shift a little bit. I was appreciative of seeing the ROI acronym, because that triggered a lot of memories for me as a parent. And I know that we have a lot of parents in our workforce. And I'm just curious, like, when a child transitions from 17 to 18 years of age, all of a sudden there's like the ROIs and everything that the parent has to fill out, or else the parent cannot have access to their child's medical records anymore or advocate for their child anymore. And so I'm just wondering, because I remember that also happened to my child when they were in high school, and they had gotten ill from Portland Public Schools, like lead in the water, hexavalent chromium in the air from the colored glass making factories nearby the schools, and just like a combination of environmental factors. And so they had to miss a lot of school. And at that time, they also went from 17-year-old to 18-year-old. And I was just shocked that all of a sudden when that birthday happened, that I no longer had access to my child's medical records and had a hard time advocating for them. And so I'm just curious, what category does that experience, which I know is shared by a lot of parents in our Oregon State workforce, what category does that fall under? Like, is that case management? Is that like
It can be, yeah, I think. I mean, it's, to me, it lands in the classic world of social work, right? And in most case management staff, there is social workers. I mean, you can even have it, if you will, around people who are managing disabled or older parents. You know, there's whole worlds of, um, you know, having medical power of attorney, you know, having release of information, having even in some cases, there's formal process of guardianship. And I guess maybe I know more about that because I took care of people that were profoundly disabled, right? And so that couldn't advocate for themselves. And so there are processes to make sure that the family has the best interest in mind. But if you have a 17-year-old, you can, who's about to turn 18, they can execute that release of information. But I think it is something that can sneak up on you. And, you know, it's just another process that people are not familiar with, right? We need to make it accessible to understand what that is and how it, why it's important and how that needs to go. And I have a fairly recent experience with trying to help members of one of our clients who have an adult daughter who has had a long history of very severe psychiatric problems, who was hospitalized somewhere, and they were trying to navigate the discharge planning with the, you know, the carrier saying, you know, we're going to stop coverage a week from Tuesday or whatever it was. And there, nobody had addressed this issue, so they couldn't even get the information, so they couldn't even participate in discharge planning. And this poor young woman was not able to make good decisions on her own behalf. It was just ridiculous. And so they got some feedback on that, but I think people need to be ready for that, particularly in the face of any disabling situation.
And MK, I just wanted to
Sorry,
add to
go
that. I
ahead,
think too,
Christy.
I just wanted to say it's also, I think it's reducing barriers, right? Like, I
Yeah.
think that's really, and I think, Emily, that can really fall in all service delivery of care, right? It's like if you're engaging with your primary care provider with a 17, almost 18-year-old, and they're having, you know, symptoms, you know, it really is, I think, in the process of delivering that care to obtain that ROI, so that there is that, you know, reduction of barriers and that continuity of care with the support of the parent, if again the 18-year-old wants it, is in place. So I do think it falls under this care and case management, but it also falls into other areas
Yeah.
of medical delivery for sure.
Yeah, thank you. And I was just wondering if we could be proactive and just anticipate that, you know, public employees with children that are 17 years old, that they may not be aware of what an ROI is, nor that they will need to, you know, talk about that with their child in order
Right.
to help schedule medical appointments or, you know, help them
Right.
navigate, like whatever encounter that they have with the healthcare system.
Yeah, and I
So
think the fact that people carry their young people till 26 on their plan, but have no access after 18 doesn't make sense to people. I mean, they don't think about it. So I think explaining that's an excellent point. Thank you. So the next case, and I don't know if you did this one, Christy, but it's to me in some ways a classic case of a person who has a fundamental behavioral health issue of addiction that has extensive medical clinical consequences, and you know is also usually one in that category of one of the more challenging types of members to engage because part of their underlying condition is that they don't really want to engage, even though they're quite ill, and it doesn't make sense to most of us that they would not. And so this is an ongoing challenge in terms of trust and engagement with people in this condition. But that doesn't mean that every effort can't be made to get them to agree to go to the next step in terms of their alcohol addiction. And oftentimes the biggest opportunity is to have that completely lined up and that be actually the discharge plan from the acute hospital, so that there's not time in between to get back to different behavior patterns. And so it really takes a lot of collaboration and co-management in terms of the care that is delivered. And sometimes, once again, we have to make sure people aren't in this sort of acute care mindset and then thinking that the next phase is something you deal with later. It's really the whole arc of a person's issue and experience and needs. So, and then anytime that somebody goes into treatment for addiction management, of course, the medical issues have to be managed, and that co-management of those things can be challenging in our system. And after treatment, there is, the next phase as well, not unlike the previous slide, where people need to be supported. So assessing whether the case management function is looking at the member and their needs over all of those transitions, and that everything is sort of teed up and ready to go, I think is part of what we should be looking for on a going forward basis with the RFP. Christy, if you have other comments, please share.
Yeah,
It looks
Christy, I
like
don't know if you have any
Sean.
comments, but yeah, Sean,
Sean does.
if
Okay,
not,
sorry.
then we can go to Sean.
Sorry, I'll just jump in there from now. But I think you can feel at this point, or at least I can, as we're going through this discussion, like how much care coordination we're talking about related to a new RFP, right? I mean, this is sort of I'll go ahead and say it. I mean, it's starting to feel kind of like a linchpin of the program at this point. It's just like the scale of it. So with that, in the same spirit, another pin to put in that is related to this sort of example, being sure that when there's a care coordination it's not just a referral, it's care coordination over to the behavioral health clinicians, that there's also a, warm handoff connection with peer support opportunities as well. And that there's not just sort of like, well, we're assuming that the behavioral health clinicians are taking care of that. I mean, we don't know that that's true, but we're assuming. And instead of assuming that, that's actually part of the actual coordination. And that's a whole different world, right? Because there's a lot of options there, and then there's the whole discussion about capacity there, and here we are again. But just kind of wanted to put that pin in the board as well, related to that.
Yeah, super important for the long term. Well, it's sort of like getting the other use of ROI, return on investment. If you will, you're maybe investing PEB's money in the care that people are getting in the intensive part of the care, but you're also investing the members' time and effort in that intensive part of the care. And for that to have the long-term health payoff, you have to be able to support them through these transitions. Because there's many stories out there, particularly in the recovery world, of people going in and out of intensive treatment, but in the interim, things are lost because these things are not carefully put together and offered up, and the person isn't engaged in an ongoing way with these next phases of care. So that is not a satisfying clinical outcome or a financial outcome, either one. So Christy, I didn't know if you had any other, or Emery, go ahead.
Yeah, I don't know. Christy, do you have any more comments on this one?
I mean, the only thing that I guess is just I heard it from Dr. Motner and through this conversation too, right, is it is really what's happening outside of that intensive care time that, you know, a lot of times leads to those outcomes. And I think especially with substance use disorder, you know, I have worked a lot in that realm as well, and that it's you know, it's easier to be surrounded in an intensive program by people who are also on the same journey, and you're getting the care and you've got control and structure, versus then when you get discharged is when you're back into your life and your, you know, your environment, and it's much harder. So I think, again, speaking to a lot of what Sean said as well with peer support and what are those other pieces in the community or within your environment that, you know, I think through case management and that coordination of care can really be beneficial and lead to those, you know, positive long-term outcomes.
Yeah, definitely. Thank you. So the next two cases are not necessarily behavioral health focused. I think they're more medical focused, but I think a lot of the potential lessons learned or improvements are kind of similar in terms of what we've been talking about in terms of that outreach. I don't know, Dr. Mary Kay, I don't know if you want to comment on some of these a little bit quickly.
I'll just make some quick comments on this one because I'll just say I'm acting as a friend supporter of a friend of mine who's going through multiple myeloma right now. So one of the things that happens with cancer and also with some other complex treatment protocols is that the delivery side of the house assumes that the person is ready to become 100% full-time patient and that there's nothing else going on in their life. They schedule tests and appointments and, you know, treatments that have, you know, followed by several days where you don't really feel like doing anything, and, you know, on and on and on. And there's not always even the explanation ahead of time of what's about to happen to you. And so, you know, transportation needs and support, food, you know, somebody making you food that might work for you, might not work for you, you know, how much care you need to take about being out and about or around other people who may have infectious disease. I mean, it's just sort of like the oncology guys are so focused on treating the cancer that they forget that this is a person who actually had a life, right? And maybe had no background in healthcare. So I think there's just a lot to be done here. Plus, it's just, you know, I know people who hit the breaking point because they're getting, I always like to think, if you've seen that first Harry Potter movie, there was a scene in the room where they were trying to get in touch with Harry from Hogwarts, and there's just a scene where all these letters are just flying around in circles in the living room, and that's kind of what the billing aspect of being in cancer care is like. I wished I could just sort of steal that little vignette. But I mean, so people like, oh, I don't know what I'm doing. What is, you know, all this kind of stuff. It is an incredibly stressful time. And plus, to Sean's point, not without its behavioral health consequences for the individual and the family. So anyway, I think people really understanding this, and so there's some great case management nurses out there who have come out of the world of oncology and really know this thing. But it's one of those things where there's a lot of aspects of what this is doing to a person's life that need to be expected, and the structure with which people are approaching helping people with this need to be very thoughtful. And also, I think one of the challenges, sometimes you see people that are going through this who choose not to engage in case management because they're spending so much time with the people providing care. So I do think that there's some opportunity to think about how that interaction between all of these interactions with a cancer center and the support that the plan is trying to give, how does that work together so it doesn't become confusing, feel like mixed messages, or people like, I don't know whose phone call I should be answering. I don't know who's going to tell me what. So I think there's a lot of room for improvement here, but I don't know if other people have different viewpoints. Maybe some of you have been through this as a family member or whatnot.
Yeah, I mean, I think that's the score, right? Just yeah. Whenever there's a friend, I also have a friend who's going through something similar, and it's like there's a community that sort of, if if you're lucky, there's
Yes.
a community around this person that rallies. There's a, what do you call it? Like meal train gets
Yeah.
set up. People start donating money. There's you know, a bunch of dinners and so on coming in. But if you're a person that doesn't have the fortune of having that kind of community around you, which Americans on average have less,
Yeah.
then there needs to be a system that essentially takes that function of like the meal train and all that stuff. Yeah, so I think that's right on. Yeah.
Yeah, and I'm kind of functioning as the what I call the medical translator. You know, so that's a different language, and we talk to people, and we don't know that it sounds like we're talking in an obscure language to them that we actually have not communicated. Um, yeah, so all of the support services and even respite care for family members who take this on. I mean, it's unbelievable what people do take on, you know. And the whole system needs to be working as people go through these episodes. So anyway, I think we're back to those comments about, are these separate items for the RFP, or is an overarching approach to how services and care are designed? Is it, you know, and maybe for somebody who needs an annual wellness check, the care management approach to that is just having a timely communication about something that's easy to schedule and you're done. You know, I mean, it could be that simple, but it is really thinking about how to make this work. So thank you.
I had two more items to throw in the mix, just anticipating our last slide of this section where we're getting to like the best practices of like
Mhm.
what might we want in an RFP. But I don't want to rush you to that point. So you let me know when you're ready.
Yeah, I think, Emery, like you were saying, that most of the issues we've addressed, and the fourth case study is just another one, although it does address the need for the family and parents to have that legal status if the person's turning 18. So I don't think we need to go through that in any detail because I think the topics are the same. And I just put this together as a way to try to pull these concepts in, but I think you guys in your comments have already know this, but it's really the discipline of putting the member in the center. And then thinking these are just categories. And of course, at the end of the day, they need to be customized for the individual because each story is unique. But to think about what care management and what service to members may mean in different types of circumstances, right? Like I was saying, for the healthy person, you just want to make it as easy as possible for whatever needs to happen to keep them healthy to happen. And acute episodes, you know, people don't know what it's like to go in and out of the hospital. There's a lot of stuff you can do to make sure all that's working okay. Chronic conditions is a whole other thing because that's an ongoing time frame of issues and things. I think a lot of people who haven't had to deal with this don't understand the sort of time commitment and diligence it takes to remain healthy with a chronic condition. I mean, it is not a zero requirement of hours and dollars, even with a good benefit plan. Some of the specifics around behavioral health that we've talked about, which maybe don't reside just in the circle, but around the whole larger circle, and then case management for these more complex situations where, you know, people are identified often coming into the system through a prior authorization signal or something like that. We haven't really talked about how to find people early, but that's a whole other topic. But I just wanted, this is sort of an approach construct that I put together. Thank you, Maggie, for making it happen on a slide. And I think, so this is the traditional case management piece, and I think you guys are probably aware of this. And so to me, the biggest challenges, I mean, Cindy and Christy took a deep dive into the middle boxes, I would say. the patient identification, how do we know who's going to need help and how do we get them early and engage them, is something that the whole industry has not perfected by a long shot. And that's something that we can think about in terms of, you know, even just communicating with membership. Hey, this is out there and it's designed to do this. And, you know, it's something that's for you. It's not something that's an additional burden. And then this last point that I think we have talked about in the context of certain cases, it's like some of the traditional constructs in case management is how many cases are open, when do you close them? Do you close them in a timely fashion? But to me, closing a case shouldn't be the goal if people have ongoing needs. And maybe the need is something other than traditional high intensity case management. But once again, if we stand in the member shoe and not the health plan shoe of delivering services, what does that transition need and how do you make sure it's ongoing? And it doesn't feel like some different thing to the person that you're trying to help. So unless Cindy, you have, or I mean, I'm sorry, Christy, if you have any other comments on that one too. Or this one, for example, because you just did the deep dive. This is sort of the quality metrics around case management.
I don't think I have anything at this time.
Yeah, so this is just kind of the stats in the traditional way that like the accrediting bodies look at case management and how they evaluate them. But I think part of what, you know, the devil's in the detail, as you, if you will, in, you know, how are you engaging people? How are you making sure you understand what their barriers are and needs are? How are you deploying those things in an effective and acceptable way? And you know, and so those are maybe some people call these softer skills because they don't come in the checkbox variety of evaluation. But these are, you know, these are sort of the component pieces that need to be in place for best in class case management. And we of course will use this in the RFP.
Yeah,
So-
and to go ahead.
Yeah, finish sentence.
Oh yeah, I was going to just say, you know, in terms of the RFP, you know, one of the things that I think we've been doing, you know, in all areas with PEB and OWEB, you know, we're trying to kind of create metrics, right, for the plans to meet. These are what we see as our best in class. And this is what you see here is going to be part of the RFP process where we say, hey, we want to make sure that you as a plan are essentially would achieve this or would provide guarantees that you will achieve this in terms of some of these harder metrics. But a lot of the things that we've been talking about before, it's like, maybe you can say that you're doing it, but are you actually providing those services? Are you actually reaching it? Are your members, not your members, are your case managers actually making the effort to go out and talk to the members or to, you know, reach out to the members and make sure they're actually following through or that you're trying to reach them rather than, you know, just saying, hey, I checked the box, they didn't answer, I'm done. So, you know, so there's definitely two aspects to this. And I think, you know, obviously that second, you know, that personal touch is something that we've been talking about a lot in this call, and that's going to be very important. So we'll have to structure the RFP to make sure that, you know, it's not just sales speak, right? It's what are the plans actually doing? And, you know, we can see that through the audits, but we're not going to be so lucky to do audits of the bidders. So we'll have to craft the RFP in order to achieve the goals in this case. But this is more of that, you know, harder. Here are some of the statistics that we see, and we would like to meet or beat some of these characteristics. Just want to add a little context. It's like, go ahead, Sean.
So well, that actually leads right into my comment. So as far as the personal touch, one thing I'd like to add, just as we're thinking about the RFP and metrics, is traditional health workers. So I'd like us to really think about what does it look like to require the involvement or the availability of traditional health workers over time in various committees and things that I won't get into. I've become increasingly convinced that the medical system's not going to be able to figure out translation services to the degree that is needed. They they do translation on the phone and that sort of thing, but they do not do interpretive services. That's different. For that, you need a person that understands the culture of the person and like really understands that language. And Oregon has this, theoretically, we have this system of traditional health workers that we're kind of not fully integrating, and it's kind of a strength that we inexplicably are not really integrating. And so something about that, as far as how do we thread that in, because for those people that need that service, it's important. So I'm just putting that out
Yeah.
there. Let's
Yeah.
talk about that later.
Yeah.
The second thing,
And Christy, I was going to, yeah. I was
Go
actually
ahead.
going to call Christy on this because she's actually part of the OF work group here on the DHWs. Go ahead.
Oh, okay.
Yes.
In
Yeah, Sean.
process.
Yeah,
Great.
it is in
Sort it
process.
out for
So
us.
well, we are trying. I appreciate your comments, and I think we are seeing, and there is some research, especially from the Oregon Community Health Workers Association, that does show the beneficial impact of traditional health workers. I also know that integrating peer support specialists within behavioral health delivery, again, is such an important piece, and that's a component of one of the types of traditional health workers. So that is in process through the CIAO Summer Work Group. We're kind of unpacking, doing a deeper dive, and really, looking at how to operationalize that and connect members to those traditional health workers as part of the OEB and PEB plans.
Thank
So
you.
more to
Yeah.
come. Yeah.
Yeah. Thanks for that work. That's good.
But
So
and it's a connect the dots thing, Sean. I mean, if we're asking the people that are doing the care and case management to integrate these things, we have to have that their education and their access teed up.
Yes.
Yep.
Yeah.
Right.
And Sean, I guess to your point, more, I don't know if this is more directly on your point or not, but you're talking about the personal health navigators, which is, another subset of the traditional health workers, I think in particular, right? We've talked, I think, about advocacy in the past, but having that traditional health worker navigator is kind of a different construct, I think, right? You're hiring someone to do it. I don't know, it's kind of like a doula in some cases, but in specified cases, but it's that tradition, that variant of a traditional health worker. I don't know exactly how it's paid for in PEB. I know for OHA, it's part and things like that, or for the Oregon Health Plan. But I don't know, Christy, if there's anything on the navigators that is being reviewed.
Are you the navigators mean as part of the traditional health worker network?
Yeah.
Yeah, I mean, I think the navigators are in place through OHA as well. I think what we're running into right now is just that a lot of traditional health workers right now are funded through grants. And it's much harder because they are not licensed providers. They're credentialed through OHA, but in kind of the current systems in place, it's hard to capture encounters for traditional health workers. And oftentimes they're kind of, again, through a grant or some type of funding that's in a community-based organization, but they are having those touch points with members. So that's really where, we're trying to kind of work on how to capture that more. And in our typical kind of fee-for-service model, it's not set up to support that quite yet.
Yeah, so you just nailed it. So that's a future, right? Because it's all about how you pay for it, right? And so that's the barrier, and that's what we've been trying to do, and that's the RFP. It's like, as long as you're stuck in a fee-for-service medical model, we're stuck. So that is the reason why to dramatically rethink the way we're doing an RFP, is to be like that shouldn't be the way, that especially around complex medical conditions. It just makes no sense because there's so many, there's 10% diabetes and 10%, it's like whatever. The point is that this person needs surrounded by support. So definitely puts us this whole conversation then goes into something about alternative payment models or something, just because we cannot allow ourselves to be handcuffed again by that. And that's like the whole system is like, well, we just can't figure out how to integrate traditional health workers because of that. And so they're not, they have credentials, but they're not, we can't bill for it. So it's like, what do? We can't figure out how to get paid. Anyway, so there's that. The other thing, and like, let's dig into it, but
Right.
it's good stuff. The other thing I wanted to just put a pin in, again, not sort out now, I'm just putting things in the like follow-up discussion. I would like to understand better how this concept of case management or whatever we're thinking for the new RFP somehow connects or doesn't to the infrastructure in Oregon related to patient-centered primary care homes, right? So Oregon has done a lot of work to set up that system, and in some ways it's quite good. But my understanding, the last I checked in, which was at least 3 years ago, was that the number of patient-centered primary care homes that we have is the number we're ever going to have, right? So in other words, there's not some plan to increase them. That might be wrong. That was just my understanding a little while ago. So there's a capacity thing, but theoretically, a bunch of the stuff that we're talking about here, some of the patient-centered primary care homes would be doing. Although sometimes maybe there's a threshold where they're like, well, this person's just too complicated, and now we're handing it off to an oncology patient-centered case management system or something, and we're just kind of like no longer our patient because they're too complicated. I don't know. Right. But it's like if the person is in a primary care home and that primary care home is already kind of managing them, how do we not duplicate? And now you have two case management systems trying to manage the same person. Or how do we expand or reinforce the already existing patient-centered primary care home manager, and be like, now you get level 2, like you now have access to a traditional health worker and this, or something. I don't know. Yeah. But it seems complicated, and I just want to be sure we don't end up with some sort of conflicting, like multiple models trying to do the same thing. One of them's by the provider and one of them's by the health plan, and they're both trying to like over help the person, and they're getting calls all the time. So I'm curious about that topic. Maybe it's already sorted out, but it's not clear in my mind how they are the same or different. So that feels like a future topic too.
Yeah, Sean, I think we can do something. It's almost like, to use a little consultant speak, patient journey mapping. Like who contacts this patient when, and if it's a patient in this care delivery model versus somebody who's not, what do the different parts of the system need to be able to deliver to get to the outcome, which is really the same outcome for the individual, right? But you don't want to, cross wires, and you might even be offering the same thing or the same advice, but using slightly different language, and it's not going to sound the same to the person, right? It's just going to make them not want to talk to anybody. So I think there are ways to do this, particularly given the infrastructure in Oregon, that needs to be valued and utilized, but certainly something we can take a look at.
And with the prior RFP, the PCPCH was definitely like essentially a requirement. So we'll definitely take a look at that and try to make it work out in terms of how some of these care management things that the PEBS board's looking for versus that versus what's currently required. So there isn't conflicts, I guess, or potential stumbling blocks in how that gets interacted. And Christy, I know you have, go ahead. And then after that, maybe we can talk a little bit about the health equity and other elements. Go ahead.
Yeah, I just wanted to add, in So in my experience in a health system was also, and I'm sure KO, you've seen this where, there were different patient journeys, as you said, with, and maybe different teams were handling that different case management, but then they had collaborative clinical rounds weekly where there were, if there was a handoff or a warm transfer of a patient to another team, those teams were connecting and, they were just discussing that patient's treatment plan. And so there was just this ongoing clinical care that was happening. And it was, if the primary care provider office or, so there was that component that I think is also another important piece to bring into the RFP to really get clear mapping and what the process and policies are in place for those different member journeys and how the teams interact to make sure that there is that true collaboration of care.
Yeah. I think people that do this work are always enthusiastic about figuring out how they can work collaboratively. And, there's some resources that the plans may have that are not available to the primary care practices. And there are relationships and resources that the primary care practices have that are not available easily to the plans, so I also feel like one of the things that we have to, if we're staying member focused, is we have to think about for the member, what is their experience of care and what is the trusted voice or source of information and services, because that's the most effective delivery channel. And that we don't always think that way. We think about constructing the resources in the list and we put it out there and it's not quite Field of Dreams. You just put it out there, they don't necessarily show up. But but really taking a look at how an individual sees this is where I get care. And just to bring up Kaiser for a minute, who I don't think does everything perfectly by a long shot. But one of the things that they have in their back pocket is that it's not confusing to Kaiser members where they go for care. Right. That's, and that's really hard in these other areas, but maybe that's the same experience of somebody that is receiving their care from, the patient-centered medical home. This is my relationship to healthcare. This is where I go. This is who knows me, those kinds of things. So you should never undervalue that. That's a hard thing to build. Speaking of which, the next slide on health equity, and that doesn't look the same for everybody, right? This issue of trust and relationship and where people go when something is up. So I don't think I need to tell anybody on this board about health equity because you guys are, I think, leaders in this area, but it does need to be part of the discussion and it does need to be part of the evaluation of everything that we look at going forward. I mean, is this working? Who's it working for? What are the gaps? Why is it not working for certain people? What is your internal process to address those inequities in impact and service delivery? And so we have a lot of things that the market in general has been looking at, including helping people find providers with congruent life experience. Like Christy's pointing out, we have, peer counseling kinds of things. So people that have similar experience with conditions, but maybe similar experience with both conditions like mental health and substance use disorder, as well as similar life experience because of different characteristics of the individual and the patient. So there's a lot of different things that can happen for people, that can be very thoughtful. There's also, back to this issue, I think that is sometimes glossed over a little bit, which is, this trusted voice issue. Like who, if your health plan calls you, is that a trusted voice for you? Or is that not? Even if your doctor's office calls you, is that a trusted voice for you or is that not? And obviously the doctor's office trust level is much higher than the health plan if you look at surveys and things like that. But how do you use those things? So you don't want to make like the health plan look like they're in conflict with your doctor's voice. So you have to think about messaging and support, or whether or not you let the doctor's office do it and you support the doctor's office to have the resources to do the outreach and engagement around these more long-term issues. So lots of considerations on sort of not what is health equity and what does it need to be, but how do you apply health equity standards as we go forward through this process? And how, and who gets to evaluate whether we're hitting the mark? Which is a little more complicated.
Just to kind of reiterate, just to reiterate a point that I think we've been discussing quite a lot. You know, this assessment of factors, that first bullet, the health literacy, you know, Mary Kay, I mean, your friends, you know, in the position of privilege to have you as a doctor kind of help being that personal health navigator in terms of the literacy and the understanding. And my parents have 2 doctor daughters to do that as well,
Thank
but not
goodness,
everybody's in the same place. Yeah. And so making sure that, you know, the members have that sort of access, I think is kind of important to make sure that, you know, they understand what, how it's their health conditions impacting them, how they might, feel trusted, right? Or have that trust in the health system as they move forward. And it's not equal by the members.
Yeah.
In this case.
And also, I think every just current education from my friend's situation, my friend had a complication that caused him to go to the ER, and his treatment in the ER was terrible, terrible. And it was, but if you asked the organization what they did about those cases, what they reported to you would have been lovely on paper. Right.
Right.
And they,
So this
Go
is
ahead.
I mean, this is the right conversation. I appreciate we're having it. It just keeps occurring to me over the years that we've been trying to get at this. It just does seem like part of the solution, or I'll just say improvement. I won't say solution. Some of the things that could be done that to make things better. And we're talking about trust. Community-based organizations probably needs to be part of the mix in some kind of formal way. Just thinking about the RFP, I don't know what that looks like, but as far as just like navigating, I don't know if the healthcare systems can do that kind of trust, you know, that kind of navigation without outside help. I don't know, but I at least want to have the conversation of like, what would it look like to more formally expect that some of that navigation assistance is formally happening with CBOs, because we've kind of been going that way a bit in Oregon. Like that's starting to be a little bit of an infrastructure to do that. And maybe that's just kind of the way it's got to be, because the healthcare system at this point already has its own culture baked in, and you can't like unbake the cake. So it's kind of like, so therefore you have to have community-based organizations just sort of fill in the holes at this point, because they are who they are.
And Emily, did you want to weigh in here too?
Yeah, I just wanted to echo how important that trust is and who's the messenger, and just, you know, it's different for different communities. And just, you know, I've been spending a lot of time with our Black, African American communities and colleagues, and I'm just surprised that this continues from I don't know, over a decade ago, that some physicians just really aren't comfortable still, or massage therapists, in touching a Black body. And so, you know, I've been in this eliminating racial and ethnic health disparities and health equity work for over 25 years. And this is a theme across cities, across states, and I'm just sad to have it affirmed again, like last week in Oregon. But there are providers and massage therapists who are not comfortable touching Black African American bodies. And you need to do that in order to get like a proper diagnosis and right for healing. I mean, I'm preaching to the choir here, but so yes, and it looks different for different groups.
Thank you.
If I may follow up on what Emily just said, we need to acknowledge the need to include people with disabilities as well, especially people with physically observable disabilities. The comfort of providers of all types touching bodies is impacted by those in ways that are not okay, not acceptable, not tolerable, and not just touching, but understanding, for example, how to diagnose melanoma in a person with a skin color that is different from ours as providers.
Or somebody with cerebral palsy can have multiple myeloma, as it turns out. You know what I mean? So yeah, I'm happy to go on, what happens with people with disabilities, and there's there's a lot, a lot there.
Emily?
Yeah, I was just going to echo that with people with disabilities for sure. And then I just wanted to share that OHA has actually approved cultural competence continuing education trainers to help providers be more comfortable with their patients that are blind or their patients that are hard of hearing. And we've gotten some evaluation results back from those trainings, and it's really been helping a lot of providers feel more comfortable with serving these two types of populations.
Excellent.
Yeah. So I know we're basically at time, but we have, I think, just 3 more slides. I don't know if we can kind of, I don't know, speed through them, but I think we've discussed a lot of these elements, but just kind of looking forward in terms of the RFP process. It's just the evaluation. I mean, we've been hearing your stories, hearing your comments, and we'll incorporate that as we discuss in structure how we want to address this area a little bit more, especially with some of those health equity, diversity, inclusion, all those comments that Emily and others have made regarding how concordance and just congruence with providers and just treatment of people should be members moving forward. We do, one of the big things is performance guarantees metrics. So we had some sample case management metrics down below. These aren't the only ones, but as we found out in our discussions with plans, maybe we do, have to be much more upfront about it in the RFP in terms of what we are expecting and requiring of the plans in this case. And we'll do this in conjunction with the PEBB board, but we want to make sure that those elements are in there and that we are trying to get those metrics or outcomes that we're trying to get, and to understand where we may be deficient, like looking at the different cohorts, demographics, races, languages, and stuff like that, and just making sure that members, or not members, but members and the case managers and providers are able to speak the same language, or at least culturally sensitive to each other in this case. Dr. O'Neill or
I just was going to say, one of the things that we could pick up from some experiences I had in ACO work is not just having metrics that we were going to look at and the ability to audit them and all of those kinds of things, but we also had within that contractual arrangement contracting around setting improvement goals and overseeing how that improvement was being done, right? So nobody's got this perfect yet, but part of the relationship between the PEBB and the carriers can be, this is how we want to see things moving. And so these aren't static dynamics, if you will.
Nobody's perfect, but we can always try to be better.
But we want them to demonstrate that they are in improvement mode.
Yeah, well, so just following that comment, there is, of course, there's a place for quantitative metrics. Like that's kind of what the system's built on. And I'm also just over the years observing that sometimes what's happening is too complicated to capture in a clean metric. So I'm wondering if, just to explore options on the RFP, something to think about and talk about is, can we leave some sort of door open? And this would, of course, would not be some sort of performance guarantee per se, because what are you guaranteeing? But that there would be some sort of formal expectation that when we do a deep dive analysis on some topic, even a qualitative study of like the workflow of how something is going, and then we have a formal like results meeting where we're saying we are observing this as a problem or a deficiency, or we would like to improve this thing, that there's some kind of formal written expectation that whoever wins the RFP, that they would be participating in an improvement project that would actually have some measurable results. Now, some of those might be metrics, some of them quantitative, and some of them might be a little more qualitative. But it's a so it's a little bit of an RFP written in such a way of like with an expectation of continuous quality improvement, and that those continuous quality improvement projects would be like co-designed by PEB and the network. And that, you know, there would be an expectation that we're, you know, they can't just be like, we heard you, that's, yeah, we'll work on that. And then that'll be that. You know, but there's actually an expectation in the contract that if we identify something that's problematic, that we will come up with a shared agreed plan of how to improve this, and that like there has to be some sort of good faith something on the part of the plan to actually like change part of their system or something. I don't know, we can't get too crazy with it because, you know, if it's too vague and we're like, we at any time we can change your entire network, you know, it's nothing like that, but it's like something where it's like a bit of an expectation that they are there is a presumption of a continuous quality improvement probably every year on something, and that we would like to have they're doing it out of contract as well as good faith, right? In other words, it's not just because we're asking them and they're like, okay, you know, but it's actually part of the contract.
Yeah, definitely.
Yep.
Yeah, definitely go ahead.
No, I think we can get that, Sean, like it's a clarity around what process you're engaging in. And I think I maybe can get at least some beginning sample language around that.
Yeah, and I guess maybe the next slide's kind of like in terms of some of those process improvements, or, you know, where we want to see things. I mean, it's like these are some of the areas that I think we want to see the improvements or the quality in the health plans. You know, some of these are pretty big, so maybe a little bit vague in some cases, but, you know, creating the guideline or the story, or, you know, like these are the tenets that the PEB wants for the members in terms of the quality. And, you know, we obviously understanding the population and, you know, the cultural and linguistic sensitivities and other things, but, you know, also outreach to other, you know, programs and things, you know, all these things that we've been talking about today. How can we write these into the RFP? How can we determine and make sure the members are engaged and, you know, or receiving these services, and writing that into the RFP in terms of the questions? You know, I think that's to your point, but, you know, that's Sean, but this is I think where we're trying to go with the RFP, and with the board's help, you know, and guidance, then we can try to have this, you know, written in there, and we'll refine it as we go through. But this is, I think, you know, outcomes or whatever, you know, are a big portion of where we want to make sure that it's actually happening. And that's really what I think, for me, the biggest thing of this RP. You know, it's like, thanks for what you're saying, but please demonstrate to us this is actually what's happening for the members.
Yeah. So the last thing I'll say on the RFP at this moment is, you know, another, you know, square here might be, you know, support for providers, right? So we've been talking about member engagement, rightfully so, but we've been talking around it several ways today.
Yeah.
That first of all, that there's some kind of built-in expectation that maybe is pretty explicit, I don't know, about the number of hours or something, like the space that providers have to take the trainings that I think um, uh, that we were mentioning earlier, as far as like cultural competence trainings or something like that. But also there are other training, that there's some space for that. It's just like not another thing that you're just piling on to providers and be like, be sure you do that on the weekend or whatever. And then there's also other things we were talking about, like do providers have access to mindful based um stress reduction?
Right.
Is that a normal expectation? Is it built into the, I don't know. But what I am hearing is that the system is under a great deal of distress, and I'm using the word stress, um, and that there is a problem with provider access because of that, and getting worse. That there is a slew of retirements going, and that we're in kind of this somewhat downward spiral related to capacity because of this. And so it's like, do we need to build that into our RFP, where that it's like there is an expectation that the provider network itself has these supports in order to support our members? I don't know. Just throwing that out there too.
Yep.
Yeah, definitely. I think the provider, uh, Dr. O'Neill and I were, I mean, on some of our internal conversations, it's like where the providers and how the engagement with the providers, is going to be addressed in the RFP. I mean, it may not specifically be case or care management. It's more network strategy, but that is a big part of the overall picture. And, that conversation, actually, if we move to the next slide, I think is going to be, I mean, it is part of what we're thinking about and potentially part of the fall retreat here, but, we are going to try to address a lot of these things. I know we talked a lot about behavioral health, but a little bit more focused next month and talk about RX. But, all these topics, I think, as we collect them and put them together and as you bring up these questions, we'll want to address it in the RP process. And maybe it's just going to be part of a collection in the fall retreat, but we will get that, try to have our discussions, lively discussions, and then create the RFP that actually meets the PEB's needs in this case for your members. So yeah, so hopefully, but I definitely appreciated everybody and their comments today. I don't know, Dr. O'Neill, if there's anything you want to close with.
No, and I know for everybody on the board, everybody's had their own experiences as well as their own level of detailed knowledge in this area. I just want to invite anyone who has follow-up comments or questions, or like, yeah, that didn't make sense to me, or you missed this glaring big topic. I mean, I am open. This is a complex area, obviously, based on our discussion, but I really appreciate everybody's involvement and interest, and I don't feel like we're going to tick a box on this topic exactly, or this approach. So thanks for having me here and letting me share sort of my experience in the industry over time, and the concerns I have today about how effective we can be for people. But I think, like Emery said, none of these things are discrete, separate categories. I mean, if August we're doing behavioral health and substance abuse, of course, this is part of it, and all of these different things. So, but appreciate the seriousness with which you're taking these issues, and on behalf of your members. So.
Well, thank you all for the discussion. We're going to take a 10-minute break, and we'll return and we'll be discussing utilization when we get back.
Thank you, Siobhan.
Welcome back, everyone. Emery, it looks like you'll be presenting. Are you ready?
I am ready.
Right.
Yeah,
I'll hand it over
sure.
to you.
Thanks.
Thank you.
Thanks, Lisa. I guess for the most of the rest of the meeting, we'll be going over the utilization report. The topics are here on the agenda. I think it's, if you've been on this board, you're probably very familiar with these topics, but we'll go through some of the big picture data and then start taking a look at trend and risk, and then diving more into specific conditions and categories. So actually moving on a couple slides. Thank you. So just to level set with everyone on the time periods and data that we're talking about, we are looking at a calendar year time period. So we are talking about calendar year 23. And that does seem, a little bit, potentially dated in terms of the time, but we are looking on incurred basis. And so we do have more run out in the claim. So we know exactly what has happened, or know better what's happened for these time periods. So we are looking at January through December 23 for the current period. 1 year prior is the 22 plan year, and then 21 for 2 years prior, with statewide choice and VOTA as the self-insured plans and Kaiser plans as the fully insured. There are some additional Kaiser costs called integrated care management fees. They total about $27 million from the current time period. In some slides, they are included, other slides, they are not, but they are kind of for managing the care of the members and non-claim services. So when we can, we've included them, such as, I think, on the next section, which are the aggregate costs. So moving on. Taking a look at overall costs for the self-insured plan on this slide, we are looking at 2 years prior, 1 year prior, the change, and then the current time period, and then the change there on the right from the prior year. So that's really kind of the line we'll be focusing on, the far right column. And then at the top section, we look at the total medical and prescription drug costs for the self-insured plans in total. So overall, there's about $750 million in total costs, and the prescription drugs are offset by rebates, as are the medical. There's some medical rebates for medical pharmacy, but they're a pretty small portion of that $641 million. But overall, the cost increased about 7.4% in aggregate, 6.4% for medical, and 12.8% for pharmacy. That is obviously bigger than 3.4%. And when we take a look at it on the per employee per year basis, it's better because employees have grown, a number of employees have grown, and that increases down to 3.8%. But that is above the 3.4% limitation in this case. Prescription drugs are increasing quite a bit, even after rebates. And is increasing for all three plans. As we go through some of the prescription drug detail, GLP-1 drugs, those costs keep going up. I know, the weight loss exclusion was not removed, but members are using more and more of the GLP-1 drugs, probably because of the diabetes diagnosis, and that is impacting the overall prescription drug costs, and that the brand drug cost on average has gone up a lot. We're talking like 20% per script, and that's just almost solely due to the GLP-1 drugs being listed as brand and the impact on that. So overall, the RX costs are increasing quite a bit. For medical, I think there's a lot of similar story. Well, one similar story I've been, I think, talking about for the last 2 years, and big part for PEBB, mental health outpatient services. They keep increasing. Number of services, number of visits, services, and the cost per service has been increasing. And that's a big portion of the 2.7% increase, at least on a per employee per month basis.
Hey,
Yes,
Emery, when the brand names go up for prescription drug costs because of GLP-1s, doesn't that mean people aren't using them for diabetes? Because the ones people are using for diabetes, aren't they generic at this point?
They are not generic. The GLP-1 drugs, no, they're not generic. They're still brand, and will be for, unfortunately, Sarah's not on, but I think it's at least a few years. I mean, they have been around for a while, but
I
just a
thought
few
they
years.
were I thought that maybe I misunderstood. I thought when they were being used for weight management, then they got an extended, they extended the time that they could not have generics. But I thought if people were using it as part of maintenance for diabetes, it was called something else. It was the same drug, but it had different names.
I had the same impression.
It's they have a different.
Impressed. I yelled at a Wegovy lobbyist at a conference last week. I lost my temper.
They have it's a different name and a different dosage, but it doesn't mean it's gone off patent yet. And so the time frame for going off patent is different for the two formulations, but we're not out of the patent time frame, I don't believe, on the Ozempic, which is the other trade name at the different dosage that's been around for diabetes.
Yes. Yeah, that's my understanding as well.
Okay, thanks.
Yeah, unfortunately, it's the costs are still the cost per script still is high. I think supply is again an issue or remains an issue, but PEB members are definitely using them in more amounts than they have been over the past year. Next slide, please. So Kaiser's on this slide in terms of the fully insured. So overall, the cost increase in tolls about 5.6%. On a per employee per month basis, it's 2.2%. So that is below the 3.4% limitation, with both medical and prescription drug costs per employee coming in below the 3.4%, with prescription drugs actually negative here. So there is I guess, better news on the Kaiser side in terms of costs, in terms of cost containment. But the medical costs, mental health services, again, continues to be a rising increase, and professional office visits. So more members are using the PCPs, which I think in some ways is good, even though it does raise costs here. And this slide does include the Kaiser integrated care fees. So that is in all of the years shown. Next slide, please. So in total for PEB, the overall increase is about 7.1% there on the top right-hand side, with RX prescription drugs increasing more than 10%, about 11%. On a per employee per month basis, you're pretty much at that 3.4%, with the self-insured prescription drug costs increasing quite a bit more than the medical in this case. Membership continues to grow 3.4%, although the members per employees is a little bit smaller. So, the cost per member is a little bit, it's going to be actually a little bit higher than the increase than the employees. So the underlying cost trends, I think we show on some of the other slides, might be just a little bit different from what you see here, because that's on a per member basis versus a per employee basis on this slide. Yep. So just, I guess there's some notes on GLP-1s and the usage of those drugs in the chat. You can read it, but basically, the shifting of drugs to GLP-1s is probably does seem to be a big indicator, and I think there's some other information on generic forms. So you can take a look at that.
Does somebody know when those drugs are going to go generic? And I realize there's ways to game it, but like, does somebody in here know when those drugs might go generic?
Yeah, so Sean put in the comment that it's basically the end of 2031. And go ahead, Trevor.
It's so long away. Okay.
I just put in the chat basically a timeline for the patent end dates. If you wanted to click on that, Representative knows, you'll have a good picture of kind of when things are going off. But that's barring any further patent extensions. Yes.
And this is Katie from MODA. I just want to echo what Dr. Bachman from Kaiser said. We do have the generic Victoza coming off patent soon, and though this is a daily injection, it still is an alternative option for diabetes in the GLP-1 space. So though members might want to choose a once weekly injection that does have a side effect of higher weight loss than Victoza, and this is going to bring, an option that has similar safety, efficacy, but a price relief coming sooner than 2031. So I think that might be a great opportunity that we're going to look forward to.
And
Yes.
we have sorry, go ahead.
Oh, I was just going to say this is Gina, pharmacist from Providence. I believe Victoza is already off patent, but we're just waiting to see how many competitors come to market, because if it does, and the generic version of it. So, if we do have generic options, we also need competition to really drive that price down. So we'll be monitoring that closely and can give you more feedback as that happens.
Yeah, and we will have a prescription drug in September, like the RP discussion, as well as some other discussions, and we can bring more of this GLP-1 discussions in addition for that meeting as well. Okay, moving on to the trend components. So we show here the total trend on a per member basis at the top, and so you can see the total annual increase. The top line in the blue is the current year. The purple line is the prior year. So you can see that on a per member basis, the cost increase was about 5.7%. The year prior was about 6.9%. And then we break out down below in the 4 sections below the various components, what's been adding, or what are each component's contribution to the overall trend increase. So utilization has been increasing, which is a little bit different from the prior year. So utilization went up 1.7%. The unit cost is going up, making up about half of the overall trend, 2.8% of points of the 5.7%. That is a little bit of a drop from the prior year. And then the member health risk has also increased about 1.2%. So taking a look at the risk scores of an average PEBB member, the risk score has actually gone up a little bit, and although it is a lower increase than the year prior. The year prior, some of that may be, although the utilization doesn't show it, some of it could be like return of services, and just kind of people getting treated for conditions that they might not have been during COVID. So that may have overinflated the risk, but overall the increase is about 1.2%, which is more in alignment with what we've seen historically for PEBB. The bottom section is talking about cost share and leveraging. So this is the impact of the plan designs. So if there's no changes in the plan design, then essentially PEBB is picking up a little bit more of the overall cost as a percentage. So of a dollar, PEBB would be picking up on average maybe about 90% of the overall cost, with the members paying 10%. So this is really kind of measuring how much a member or PEBB's picking up in relation of that total healthcare dollar. And in this case, there isn't really any healthcare cost share leveraging happening this year. Prior year, there was a little bit of an impact. So one of the things with the unit cost, you can see the bullets down there below, outpatient services. Depending on the different plans, some of the outpatient services increasing, outpatient facility costs, professional services, so office visits, the typical office visits, those costs have definitely been increasing on a per unit cost basis. So we talked about some of the stressors earlier today with providers and healthcare systems, and maybe nurses not access of supply of nurses and other issues, and there's been, I think, continued talk over the past few years, less during COVID, since COVID, on like how they need more providers and facilities need more money, and the contracting is getting more and more difficult. And we're starting to see that show up in terms of the unit costs here. So those costs have been increasing. We talked about specialty drugs, pharmacy specialty drugs are increasing. We talked about Ozempic, and then unit cost. COVID vaccinations are kind of like, those were quite big, quite a lot of them in 21, 22, and the cost of those vaccinations were actually pretty low, at least on a per service cost. And so removing those basically makes the average cost per service go up. And so COVID claims, COVID admits, COVID vaccinations services have been going down, and that's kind of been playing a role, at least in the 23 cost changes in this case. Next slide. Taking a look at it by the different service categories, you can see on the two ends, those costs actually have gone down. Inpatient's been about 4.2% drop, and all other services 4.7%. So all other services would include COVID tests in there, lots fewer COVID tests and lab services, so that's impactful there. For the inpatient, it says unit cost, but that's actually DRG changes. So basically the admits are of a lower acuity, and that's impacting the overall what we call unit cost in here. So member risk is calculated in total, so that doesn't change, but the admits actually are lower acuity, and that's really driving the inpatient cost down. For outpatient services and physician, the costs are increasing. Physician, you can see the impacts, especially on the unit cost there and utilization. So more office visits, more mental health services, but the cost per service is increasing about 4% on average. So that is driving about half of the physician cost increases. And in prescription drugs, again, Ozempic was a big driver in this case. Any questions before I move on?
Yeah, Emery, Mr. Sean, have you seen any studies at this point? There's been a little bit of time that indicates that the healthcare deferral during the pandemic has now come home to roost, anything like that? Or did we kind of dodge the bullet mostly? Or yeah, have you seen any national studies or anything like that that just kind of indicates one way or the other?
I haven't seen one, like, at least I don't recall one being pinged to me. I know there's been some of those studies. Dr. O'Neill, if you heard the question, I don't know if you've seen some studies on how I guess the impacts of COVID on members' health or post-COVID.
There's a lot of research that's sort of finally surfacing on the impacts of post-COVID syndrome, and it's actually pretty common, and it also, there's not a decrease in the risk of it as people have second and third infections, right? And so people can still be getting this condition. There's nothing compared to what we were dealing with before, but there is an uptick in cases nationally right now, with more people having COVID, infections. And so they've characterized, they've done some standardization around what is post-COVID, what symptoms do people have, timeframes and things like that. And a fair number of people have some kind of lingering system. It can be as long as a year. And I think the struggle has been that some people have very profound symptoms that are very disabling, but other people have these conditions that are kind of impactful to them, and impactful probably more from the PEBB perspective at work than they are from a healthcare utilization perspective. But I think a lot more will be learned about this. The other thing, of course, is that from a services perspective, there's been a limited amount of access to care for people with this condition, with providers who really know what to look for and know what to do. So it's kind of a challenging area right now, I would say. But the research basis for understanding the condition, the prevalence, the array of symptoms, and those kinds of things is improving. I don't know. Don, if you've seen more people address it from a care perspective than before, but it's one of those really tough situations, I think, clinically speaking.
I haven't seen anything more specific than what you were seeing. You characterized it pretty well. Long COVID and post-COVID syndrome, I think, are often used interchangeably.
Yeah.
And if there are more definitions than that that have been made official. I don't know what they are. I did want to come back to Sean's question, though, because I interpreted it differently. My interpretation, Sean, of your question was, has there been deferred care from during COVID that has come home to roost in terms of utilization, not specifically from people getting infected with COVID, but from the impacts of COVID on the whole system and all the things that were shut down and care deferral, and have we restabilized? Has all of that deferred care now been obtained, and have we gotten back to some kind of equilibrium, or are we still seeing the effects of deferred care increased, perhaps hospital-based or more intense utilization because people hadn't been able to get their care? I don't know, those kinds of implications. Sorry, Sean, I don't know what you actually intended, but that is a question, if it isn't what you intended, that I'd like to understand the answer to.
Thanks, Don. Yeah, that's what I was asking.
Yeah. So, Sean, yeah, like I said, I'll have to do some research on that for you. I'm sure. I think I remember seeing some stuff. I can't recall off the top of my head.
There's been a few studies, I mean, not specifically on your data, but some studies regarding at what stage is cancer being diagnosed after that time frame, where people might have been more reluctant to go in with earlier symptoms and things like that, or their screening protocols were delayed because of COVID and the shutdown. So there is some data out there, but I think Emery, you and I can help dive in on the bigger picture questions about what we're seeing and whether that delayed diagnosis indicates that in certain categories, the people that have those conditions are sicker at presentation.
Yeah, I tried to tease it out with our internal informatics team, and this is like the data is just like it's like messy. I mean, this is like,
really hard.
It's hard to draw conclusions based on.
Well, I think Dr. Bachman in the chat also has a related good point, which is that I think regardless of the cancer diagnosis, which is in itself a good question, and such things, you know what I'm saying?
And like such things,
yes. Increase, I think there was a measurable increase in overall weight among Americans, which increased risk of prediabetes and diabetes over the system, that sort of stuff. And there was unquestionably, I think, a massive impact on the behavioral health system, which seems fairly obvious to me at this point that we're experiencing that in PEB and will likely continue. So maybe that's kind of like the main outcome at this point, as far as like the impacts on utilization going forward, because I don't know if anyone else has a different perspective, but I don't see that kind of returning to pre-COVID baselines anytime soon. So there's that. And per our last discussion, we have yet to crack that nut. So that will continue to be a pain point. So it kind of feels like pharmacy, behavioral health are kind of like two big spots of pain right now for our dashboard, if you will.
There's definitely data on increasing rates of alcohol use disorder in relationship to COVID.
Okay. Moving on to the next slide, just taking a look at each plan in particular, some of the biggest changes. So we have a list of essentially 3 of the biggest components change, whether positive or negative. So taking a look at province there at the top, especially drugs in the prescription setting, so the PPM, you can see listed in the first bullet, there's the Skyrizi, Humira, the increased cost and use of those continues to grow. And I think they've been growing for, I don't know, the last 8 years, but it continues to grow there. And then you can note the prescription drug retail there on the right. That's Ozempic and other GLP-1 drugs impacting that. For statewide prescription drug retail, again, Ozempic usage is a big part of that, and then specialty drugs. So it's kind of similar to Providence, not surprisingly, with just those two categories flipped. For MODA, there's a big drop in the facility outpatient specialty drug, but as you can note down below, it's really kind of like a shifting of services or a shifting of site of service. So that's not necessarily a true drop, but site service has changed, and hopefully that has reduced the cost of that drug. But specialty drugs, again, increasing, and outpatient mental health services, which is Kaiser's biggest increase, the mental health other outpatient, and Kaiser HMO's second biggest increase. So mental health other outpatient, it has been increasing quite a bit. I think it's been on the list for the last, 4 utilization reports. Additional usage, I think just the openness about talking about mental health and just, acceptance, I guess, to me, acceptance of mental health and trying to treat mental health issues has risen in terms of getting these services taken care of, and hopefully we see the long-term gains from that in this case. And then for Kaiser, go ahead.
Actually, finish your thing. Sorry.
No, it was a quick thing on Kaiser. Kaiser maternity did go down because the more expensive cases were fewer and lower acuity. Go ahead.
Well, I was just thinking, because we're dealing with the behavioral health, I don't know if you want to call it a crisis at this point, but it's a thing. And pharmacy. I know we've talked about this a little bit when we've done special topics on these things, but I'll just bring it up again for our next sort of deep dive. Just talking about adapting to the new reality. Are there things we can do related to site of care, related to both behavioral health and, maybe we're talking about, increasing peer support, something versus intense, and I don't know, some kind of site of care discussion, and with pharmacy, same discussion, 2 different topics, right? Just because, you can see here, there's a little bit of, you can move a few things around, and it can make some difference when you're trying to roll with a punch, so to speak, financially. And so I'm just wondering if that might be a topic that we could get some more mileage out of with different plans. I don't know. So just throwing that out there.
Yeah, site of care. I mean, the obvious one, I think, prescription drugs. I mean, is an obvious one, but some of the other site of cares, I think, MODA in the renewal this year, provided some potential shifting. I think we're talking about member, care management aspects of it too, right? And so, yeah, definitely we can look into it a little bit more. I think we're getting some tools, at least in the database, that we might be able to really dive into a little bit more, and that might be more of an IWG type of thing that we could do on the site of care. But it is going to, those sorts of cost sharing savings, more efficient use of services or where services are being rendered. It's a big part, I mean, of trying to get those marginal savings to help reduce the trend. And yeah, definitely part of the RFP in terms of data. We can work on it a little bit more.
And I guess I meant specialty drugs.
Okay. Specialty drugs. Yeah. We can look a little bit more into it. I know, I mean, Providence and MODA, it's some of the programs that they give, and every year I think we ask for more, like what's being shifted and what can be, how can those costs be lowered.
Okay. Well, I'll leave it to you. Like, if it's not worth drilling into this, we've already tapped that out. Let's not waste time. But I'm just throwing it out there.
Yeah, no, it's definitely worth doing, but it's definitely worth doing, because that is, like I said, part of the savings that we've seen year to year in the renewals, and helping meet that limitation. Okay, Next slide. Okay, so just kind of taking a look at the pharmacy trends, that the sub headline, non-specialty drug trends actually growing faster, and especially due to GLP-1 utilization. So if you take a look at the percent changes there, so total drug costs in this case on a per member per month, per member per year basis, about 10%. But non-specialty drug in the PBM is increasing about 13%, 12.7%. And as mentioned before, the GLP-1 drugs get put into there. And so while specialty drugs is still increasing at quite a bit, 11%, the non-specialty is actually increasing by quite a bit more. And then the professional and outpatient, professional, especially in outpatient facilities, especially, it's not increasing as much. And some of this, I guess, to your point about Deshaun with the site of care, some of it may be shifting more like up. So outpatient facilities going to professionals going to the PBM. And so that's potentially part of the PBM increases. But looking into doing that and moving into the lower cost settings, it's something that, the plans, the plans have been doing, and we'll just keep focus on the plans in terms of trying to manage the costs. But yeah, being more efficient in terms of where the services are being rendered in this case. Okay, a little bit more detail on the next slide on the PBM pharmacy. Thank you. Taking a look at the top drugs there. Number one, Skyrizi in terms of the cost increases. So that's been increasing. Stellaris number 3, but then 2, 4, and 5. With Ozempic, the cost increases from year over year, different kind of formulations of it, the milligram doses. So overall cost increase, we are talking about like $6-7 million for just Ozempic. And then you got Mounjaro coming in number 7. So that's another one, and I'm sure every pharmacy person's like screaming at me to list the other GLP-1 drugs here. But you can see that the cost increases for some of those drugs. The Jardiance, those are increasing quite a bit, and they're not. Some of those GLP-1s are non-specialty, and so that's causing the non-specialty drug cost increases. But members are definitely using it a lot more, and it's impacting the overall cost. We'll have to see if there's going to be improvements in members' health over time due to lower weight. But that, a lot of confounding factors. So we'll have to, know what we'll be able to tease out as a result of that. But that don't expect immediate savings, but potentially something longer term. Yes.
Do actuaries have any way of testing the claims that not just these weight loss drugs make, but other therapies do too, about if you put a prevention thing in place and it's widely used, you can find a way to predict what it might do to your premium? I mean, because that's, I have sort of forcefully shoved back and say, look, I'm not allowed to take the savings. It has to show up. I've got to plan for the premium that I have now. Thank you very much. Is there a way that smart people who do math better than me have figured out how to do this? Of course, maybe if they had, these drug manufacturers would show it to me. I don't know.
So
the answer is no. That's fine. I just want.
No, I guess I'm just trying to figure out which question I'm trying to answer right now.
Well, I want to know is there a way to reasonably predict the savings? I mean, I get it. Like they have a point. Like obesity does contribute to a lot of health challenges, and if there was a way to say, okay, I'm going to keep you from experiencing those, like we ought to see the benefit.
Yes. And
in 2030 when they go generic.
Yes. So I think there's definitely ways of doing it. I think there's definitely ways of doing it. It's there's information. I think it's just a lot of assumptions. I don't know. There's ways of doing it. I can't get you a good answer right now. Yeah, go ahead.
Emery, I mean, one of the things about this is you can talk about the disease burden in the population, the likelihood of prescribing these medications, the cost that will accrue as these prescriptions are written. And we do also have some information. I just looked at an update. There still is a pretty big drop off of people who start Ozempic and stop it. I mean, I don't always know the reason. Some of that could be out-of-pocket expenses. Some of it could be side effects. Some of it could be other issues in the person's life. But so you can do that sort of time frame analysis of the benefit change. So then if you want to start looking at, can we book savings on the health impact? That's a wholly different timeline, amongst other things, you know. And sometimes I've thought that really great employee-based health plans should get kickbacks for delivering healthier people to Medicare, for example, right? When is the when is the return going to come home, you know, on these things if you really help somebody get healthy? And as a physician, I'm like, let's do it if we can make things better. But so, you know, what does it mean to help people be healthier, and when is the impact of that work going to come home for the individual and therefore the population and the system? So that's one of the big challenges. Ollie's going to tell me I'm crazy here.
No, I'm not going to tell you you're crazy, but I know, Ollie, you had your hand up, and I think, yeah, but just, I don't know if this is quickly, but one of the things, and this is part of the RFP discussion that we had earlier today, it's, you know, we're talking about the health impacts, but personally, it's the health impacts and the stressors there impacts my work, hopefully not this work, but, you know, your workforce is going to hopefully be better off as a result of what we're trying to do here. And that's a big part of, you know, what Oregon PEB is, right? You know, making employees healthier and just better. So hopefully all these things, you know, maybe those Ozempic's going to help the workforce. You know, they're not going to have so much back pain, and they're just going to be able to work more. Work more. No, but, you know, it's like work better. I don't know, just better in that case. But there's other confounding impacts as well. Ollie.
Yeah, thanks, Emery. I was just going to say, from the frame of a physical impact statement and going like to Emery and trying to quantify, you know, the impact of a piece of legislation that has potential, you know, ROI of savings like this. I don't know that LFO would let us count that now for these for GLP-1s, but I think, you know, as more data comes out, I think that that's something we could cite and maybe start putting on the form and getting some credit for it. Thanks.
John, did you want to make a comment, or?
I mean, I would just in general, over the years, if we were able to count every time we have a cost savings, our current health insurance would be free, right? I mean, if you got to count it all. So, I mean, on some level, just take a step back and look at where we are. We've never had more drugs available to Americans for more treatments, for more things ever. And yet our total, you know, average lifespan of an American actually went backwards. So,
yeah, but
you know,
Sean, all those people
like
want to be paid. All those people want to be paid, Sean. We're not, it's not free. They all want to be paid.
Right. I'm just saying, like, pharmaceuticals are not, we're not going to solve health by prescribing our way out, is my only point. Like, it's good.
I don't know, buddy. Like with this Ozempic stuff, it's pretty incredible.
Well, we might. We'll see. I haven't seen it.
It reduces your cravings.
It's still with the weight loss data that I just took a look at, about 25 to 30% of people stick with it. I mean, something's going on there.
I just put in a chat too that the ICER report, which is the Institute of Clinical and Economic Review, and this was back in 2022, so they don't have an updated version yet. But for obesity management, really, they do come up with benchmarks that are really that effective, cost-effective threshold. And as of 2022, they believed that the Ozempic and Wegovy needed to be priced about half of what it is right now. And that would be future medical cost offset, like stroke prevention, cardiovascular disease, and things of that nature. So I think we are eventually going to get there, but right now the cost threshold, it's tough to reach it.
And it is a good point that I think a lot of those cost savings probably would be captured by Medicare rather than, or maybe at the very end of PEB life cycle. But yeah, especially for people that go on the drug, like in their last, say, 10 years of state employment, that benefit would be captured by Medicare. I think most.
That's a really interesting point. Single payer. Go back on mute.
Yeah. Well, thanks for the lively discussion here. Yeah, I know we're going to be talking about like GLP-1s some more. I mean, it's something that we're going to come back to, and I know the great interest in it. So I'm sure we'll have more of these conversations. But moving on to the next slide, just kind of taking a look at medical pharmacy. I won't go in much detail here. There's different drugs or like injections or services that are being performed. Some of them are very small and very costly, like Zolgensma, which is the #1 for spinal muscular atrophy. And, one of those is $2.2 million. And so you have one that shows up on the top cost increases. But some, you can peruse this, do some Google searches or whatever you want on it. But I think just in the interest of time, we'll move on. Next section, we'll talk about risk and efficiency. So next slide, please. So the overall PEB increases there to the right. We do normalize the risk scores on average to 1.0 for calendar year 22. So we can see the increase in 22 to 23. So back on the right, total PEB is up to about 1.01, which is as mentioned earlier, 1.2% increase if you want to add out the additional decimal. Taking a look at the changes by the different plans, Kaiser is on the left. Kaiser deductible has actually increased a little bit more, at least percentage-wise, but remains the lowest risk membership on average. Kaiser HMO is the second lowest. There is a little bit of an increase there, kind of in line with total PEB. Moda from 22 to 23, their risk actually increased a bit more, 3%. But there's some risk migration that we'll show on the next slide. Just talking about 23 to 24, but Moda's risk did increase a bit more than Providence Choice or statewide. Providence Choice increased a couple points, and statewide actually basically dropped just a little bit in this case. So we're just kind of seeing the risk of the membership. Statewide has the highest risk membership, overall, I guess the members, at least on the risk basis, haven't been increasing that much. And I think based on the renewal results, if you remember, Moda and Providence Choice did have bigger increases than statewide. Some of that's because statewide risk isn't increasing nearly as much as the other coordinated care plans are. Next slide, please. So taking a look at open enrollment. So basically what the members in the plan as of 23 and the risk scores at that point, and then those people, the plans in January 24, based on open enrollment and people coming in and out of PEB. We don't have information on the people new to PEB, but we do have the people leaving PEB. But taking a look at the members, they're at the top, and then the risk scores down at the bottom. So you can see that Providence Choice is the second largest, or is the largest plan, statewide second largest, and then you get Moda, Kaiser HMO, and Kaiser deductible. The vast majority of those members did stay in the same plan. About 6,000 did switch into a new plan, so they moved from the old plan in PEB and into a new plan. And then so there was definitely some switching. And then if you skip over 2 columns, you can see the people switching out. So generally, MODA did get more enrollment again in January. So about 1,800 members switched into the plan, 800 left. So basically net of about 1,000 additional members there. And then they got some additional new members from PEBB, another 1,000 new members to PEBB. And so they weren't in the health plan before 23, and then lost only 500. So overall, MODA's enrollment continues to increase, and they've been pretty much the biggest increaser over time. For Providence Choice, they did increase, but not very much, at least as a percentage, and statewide did see a drop. For Kaiser, there was a bit of a drop in deductible and HMO in this case. But if we take a look at the risk scores down below, so December of 23, you can see what the risk scores on average was for the members in each of those plans. The people remaining in the plan generally, the vast majorities of the members remained, and their risk scores are pretty similar to what the average risk score was. But those people who switched were actually lower cost. So there's some switching of lower cost members into and out of plans. Generally, switching out of MODA were some of the higher cost members, and so they got a little bit better enrollment or better membership as a result. Province Choice and statewide were kind of not much difference between those switching in and out. For Kaiser, they got a little bit higher. Some of those switching out were actually some of the lower, at least for deductibles, lower cost or lower risk members. And then in the column to the right, you have the people who basically left PEBB. Some of these people are potentially retired or went to another job. Retirements or leaving PEBB might be older members, and so as a result, their risk scores are typically higher. And so you can see that the people leaving PEBB are a little bit higher. In terms of new members to PEBB, typically those might be lower. We don't have information on them, but generally we would expect those to be probably close to that 0.9 or below risk score. But overall, in terms of open enrollment switching, there isn't much difference between the plans. I think MODA did drop a little bit, but all the other plans kind of stayed within a point of where they were. So the switching really isn't impacting PEBB too much. It's really kind of the PEBB plans much. It's really, so the plans will kind of manage a very similar population. And so we'll see how well they do in terms of the costs in managing that population for next year. Okay. Next slide, please. This slide we kind of show to what we say is the efficiency of each of the plans. So basically taking a look at their average allowed cost per member, adding in admin, integrated care management fees, taking out rebates, and then essentially normalizing it to a 1.0 risk. So taking out the fact that, Kaiser's risk is a little bit healthier statewide and MODA's risk is a little bit more expensive. What we want to do is normalize and put every plan on an equivalent basis for overall cost to just kind of compare it on a per member basis. And MODA's coming through again as the lowest cost after normalizing. Statewide and Providence Choice are pretty similar, with statewide actually just $4 below Providence Choice. And then Kaiser's plans, you can see there on the left, when we normalize for risk, are higher cost than the other plans. Rebates, again, mentioned rebates and integrated care fees and other admins included in this case. Okay, next slide, please. More deeper dive into some of the clinical conditions here. So, I think same story, we've talked about it. Top category there on the left, some of the increases where it's been increasing year over year on average. So mental health with anxiety and depression, number of members who are getting treatment for those services continues to increase. We talked about outpatient services and other things, but yeah, this is, one of the biggest increases in terms of number of members in this case. Down below, cardiovascular hypertension is increasing. It was pretty consistent from 21 to 22, but bigger jump in 23. Chronic heart failures, a bigger increase on a percentage basis, even though number of members is low. So that's something to look into. Asthma, I think during the COVID time period, that's been increasing quite a bit. So it's continuous continuation of that increase in this case. But really, that diabetes and obesity, I think, with the GLP-1 drugs and the popularity and just the notice and people getting treatment and getting diagnosed with it more, that's, I think, that's a huge jump, right, from where we were in 22 and 21 to where we are now with diabetes, and diving more into those members and how many of them are taking Ozempic, shifting to higher cost drugs versus the older cost ways of treating it. That's driving a big cost on PEB, as you can see down below, which is the total allowed for different types of conditions. Diabetes is number one. It increased 1.1 points of PEB and went from about $43 million to $54 million in just 1 year. In addition, a lot of it's dealing with the patients, but also the services there. Other things down below, I think autoimmune, so some of those especially drugs impacting that. Depression, number of patients is increasing, although the spend is not increasing as much, but the office visits are increasing, so maybe fewer higher cost patients in this case. And pregnancy costs actually did drop a little bit, so maybe there's a post-COVID baby boom that's decreasing. Dr. O'Neill, is there anything you wanted to comment on in terms of clinical conditions here for PEB?
I don't suppose anything is surprising here, but some of the issues are sort of got relationships with each other. With the musculoskeletal low back disorder, we know activity levels can be very helpful with this. We know a lot of people became more sedentary during COVID, not everybody, but many. And that there's always an interplay between these chronic medical conditions and the behavioral health status of people. So I guess none of it surprises me particularly, but I think there is good upside with a number of things that we've been talking about helping people with engagement around their health behaviors. And I would expect over at least a few years to start seeing improvements in some of these numbers if engagement is successful.
Yeah, the diabetes chart seems worth further discussion at some point. That looks like a deep dive. Like,
yeah.
Wow. So that seems worth it, worth our time, just given the scale. I would also be curious, given our discussions earlier today about, whatever I don't know what the right word is, alternative therapies, like mindfulness-based stress reduction and peer support, this sort of thing. I would be curious what goes into the anxiety and depression numbers. Like, how is that cake baked? Is it like mostly clinical office visits? Is it, just what goes into it, and then to see like what proportion of our spend goes towards some of the other types of treatment for that, or supportive treatments or whatever, or is it are we mostly just looking at the clinical sort of intense interventions or what have you? So I would just be curious about how that number comes together to look at further some point later.
Yeah, so this is based on diagnosis codes. So, it's just like members flagged with that. So if they had a service with anxiety or depression, then they get noted. So if they don't go see a doctor and maybe they use some of the mindfulness things, that's not going to be flagged in this case. Or the costs aren't going to be flagged. It's basically on encounters in this case.
Okay. So even if they're
visits,
referred by a doctor, it wouldn't be captured?
Well, if they're referred by a doctor and the doctor put it on the primary care visit diagnosis, the 1520, then it would be captured in that case. But
Yeah,
the cost of it?
The cost of it, I will have to double check if the information there on the right. The office visit itself, I don't think the outside, the claims, the app itself would not be.
Okay.
If that's what you're asking.
That might be something to think. Yeah, I mean, that's part of the problem, I guess, is
yeah,
like maybe we're not even paying for it, which is why it's not happening. I don't know. So Okay.
Yeah.
But I think there's been a push over the last number of years for increasing screening in the primary care setting for anxiety and depression. And if they screen and get a positive score on that screening test, then the diagnostic code can hit the, the claim, the information that Emery's referring to, that's the basis of the analysis. So there could be people on here that have been screened in for this and aren't clearly receiving exact treatment for it. You know what I mean?
But
Yeah.
I don't know. Yeah. Sorry. Go ahead.
No, I was just, it's just an interesting topic to sort of dig into, like, what are we really paying? And are we paying the most efficient support for those people? Which I guess is the same question for the diabetes diagnosis, for that matter. Anyway, we can talk about it later. Just curious.
Yeah. I mean, I think we touched upon it, or like with the RP discussion. I mean, right. It's like making sure that we get that reporting and understanding of who's using all these ancillary programs, if they've been referred to it, is it helpful, and other things like that. Just if there's an app for it, are people using the app for it and getting that reporting, and if they've been like referred to or whatnot, that sort of thing is just helping getting that ROI, the second version ROI. But the return on investment on these apps. I mean, there's one client is like, yeah, we're getting rid of this app because no one uses it. It's like, oh, well, you've been paying a lot of money for something that nobody used, and there are like thousands of members. It's kind of like, well, that wasn't helpful at all. That's a nice waste of money. So, but getting that information would be great. Okay. Moving on to the next slide. Preventive screening rates. So the screening rates actually have increased a little bit, like couple points. So the preventive visits there, from left to right, essentially the year. So 2023 is on the left in light blue, and then purple's the last year, the year prior. And so you can see the screening rates have increased for employee preventive visits and spouse preventive visits. So that's going up a couple points there. Breast cancer screening did tick up again, 52%. So it is higher than where it's been the last couple of years. Cervical cancer, which is the fourth column, actually is a tiny drop in this case, but pretty similar. And I think there was some, I don't know, Dr. O'Neill, wasn't there some like change in like the scheduling or something of the cervical cancers that might be impacting that?
There's several things there's several things. Are you referring to cervical cancer specifically?
Yeah, cervical cancer. Yeah.
Yeah, they changed some of the age range in which people are screened for that. And there's also been, even though there's still screening recommendations, also, the vaccine for HPV has really changed the sort of profile of what's going on for the better, thank goodness. So, and also there's been a change in the breast cancer screening age range, which is increasing it, right? So these things are evolving constantly, and also and the colon cancer screening, I assume that we're gathering all the information regardless of test type. It's not just colonoscopy.
Yes.
So that's an important thing, and obviously that's an area where there's always opportunity for improvement.
Mm-hmm. Yeah. But overall, I think this is a little bit different story than I think we've been talking about over the last few, where it's like in the past, we've been going like, well, preventive visits, screenings have been going down. This is, there's been an uptick in this report compared to the last few. Okay, so the next section, we're going to dive a little bit more into the different categories of service. And then the executive summary, where I kind of hit most of the highlights, and then just go into more detail on each of the following slides. But inpatient facility, I think talked a little bit about this, flat admits, but the DRGs actually decreased, which reduced, or the intensity of the DRGs reduced, which decreased the cost per service. Outpatient office visits, I think I hit upon the cost increases there earlier. Emergency room visits. I think, again, very similar story to what's been before. Visits continue to increase with lower intensity or non-emergent visits, really driving the growth here. I think we talked about in the past about potentially upcoding. Right now, it's just lot more, definitely a lot more non-emergent visits, and trying to get that to a more efficient usage, or using telemedicine or other things to try to impact that. But that's driving not as much as some of the others, but it is driving cost increases for PEP in this case.
Emery,
Yes.
what I've been hearing from some of our members, maybe I don't know if other board members have heard something similar, but there's the perception that there's less availability for timely appointments with people's primary care doctor, just less available. So you go to get an appointment and it's like weeks away, and it's not maybe an emergency, but it's not a weeks away to wait kind of thing either. And so they just end up like, well, okay, I'm just going to go to the emergency room, or even urgent care, but that might be what's happening. So there might be a bigger story here about provider availability, turnover, like network adequacy. I even hate to say that because that's its whole can of worms, but there's something about like turnover among availability of appointments. I don't know, higher utilization, less doctors, something. And so I don't know if that's a topic, but it feels like if we're going to open up the can related to the what is happening with emergency rooms, there's an easy answer that I think everyone that the market reaches for, which is like, just make it more expensive, and then people will correct their behavior. But I think there's a bigger story about a perception of scarcity related to access. And so I'm just putting that in there. I don't know what we do about, like, if that's a discussion, or if there is a way to open that can of worms somehow in some sort of systematic way. But that's just throwing it out there. That's what I've been hearing.
Okay.
And Sean,
Yeah.
there's also the ability of people to navigate the healthcare system at a particular hour of the day around work and other responsibilities that can drive
that.
ER utilization as well.
Yeah,
So
good.
yeah, there are ways to look at this. So
Yeah. Emily?
Yeah, I've been hearing the same too, Sean, and especially in the Eugene area. So a lot of people have like lost their regular doc that they've had for years, retired, or people have been burnt out too, I think, from COVID. But then also it seems like there's non-compete kinds of situations that are impacting our providers who still want to provide, but maybe not in the other system that they were in, that they've resigned from, but they're not allowed to provide in a different system. They can't even volunteer in their community. Or I've even heard stories of people trying to apply for public health positions as they take a break from burnout from COVID, and that's not even allowed in some of these non-compete arrangements, I think. Those are just anecdotal things I've heard.
We'll take that down, Emily, and take a look into some of those questions. We might have to go to the plans for their input on some of those. I will definitely note it. Ali?
Yeah, those are great comments. I think it's not inconsistent with what we hear in the office. Just to note that we'll be providing our comprehensive report on access, including our equitable access to providers across the state. I'll have to look at the work plan, but it should be, I think, believe in a couple months, either August or September.
Thanks. Okay. Thank you. So just, I guess the last two bullets there, I think the final one we've already talked about quite a bit, but lab and radiology, just the post-COVID impacts, fewer COVID, basically almost none COVID tests being performed. And that was a big cost in 21 and 22 in terms of lab services. Okay, so moving on to the next few slides, although, just quickly taking a look at this, the admits, again, basically flat, and then the loudmouths decreasing as a result of the DRG changes. One note below, with the Ozempic and weight loss, obesity surgeries, DRG 621 did increase by 22%. So in terms of the weight loss, people are still, it's not just GLP-1s. I don't know if they're denied for GLP-1s and then, aren't diabetic and getting obesity surgeries as a result, but that is something that was interesting in terms of obesity, and part of that obesity increase that we talked about on the chronic conditions, the number of surgeries has gone up quite a bit in 23 compared to prior years. So that's something I found interesting. Next slide, please. Outpatient office visits. So, the change, at least overall office visits is kind of flat. PCP visits are increasing, but the allowed per office visits gone up quite a bit. So about 8% on average. You can see pretty much all plans are increasing. And then that note below, which I think I mentioned earlier, E&M office visits. So those specific CPT codes. Per visit, the cost, allowed cost per visit is increasing 7%. So the underlying unit cost of those services is going up, and that's driving some of the impacts for PEBB. Okay, next slide, please. Emergency room. So ER visits up about 3.7%. The biggest increases there are in Kaiser deductible, which is increasing 12%, and Kaiser HMO increased 7%. The cost, the allowed amount per ER visits, increasing a little bit, but not as much as it has in past, 2.3%. But and part of that's because the level 4 and 5, the highest intensity visits, have gone down a little bit. Level 5 decreased more than level 4, but both of them did decrease. And then, as mentioned before, non-emergent visits, it's gone up from 18.9% of ER visits to about 20.7% based on the NYU algorithm of for ER for diagnoses to say what portion of the ER visits may be not emergent, but that's increasing. So, another point of maybe not almost 2%, 2 points of not efficient usage, whether it's because they can't access it, access PCP providers, it's too late or whatnot. That's driving some of the additional cost here for ER. And so next slide. Lab services, the visits, the services went down 4%. Allowed cost is going down as well. Again, COVID tests decreased by about $7 million. So some savings just because COVID tests are essentially, done at home, or no one's testing for COVID really anymore. It's just under $200,000 in lab services in 23 in this case. And then next slide, right, which is, I believe, radiology. So this one, radiology services, the services per thousand, you can see are increasing. The biggest increase is Kaiser deductible in this case. The cost per service for Kaiser has increased between 8 and 9%, with Kaiser HMO increasing 8%, and for Kaiser deductibles 9%. Some of it's mammography, so the changes in the ages for the breast cancer, so that's driving a lot of the increase in this case, as stated before. But overall, radiology services are going up a bit comparatively. Next slide, please. Okay, so the next few just kind of talk about the prescription drugs. Overall allowed, again, big increase, 11.7% increase. Allowed paid's 12%. So basically, the cost sharing is remaining the same. So PEB's picking up a little bit more of the prescription drugs, and maybe the prescription drugs like Ozempic's more expensive, so the copays don't cover as much. The self-insured plans, you can see the ones on the left, they're increasing. They're the drivers of the increased Kaiser plans. They're on the right, decreases. Overall, I think, the story that we talked about a little bit earlier, and you saw some of the reasons for those increases a little bit earlier. Next slide. One more, please. Thank you. This is excluding specialty. Actually, Sean, you had a question?
Yeah, quick question. Immunizations, where does that get baked in?
Oh yeah, I was going to answer that. So immunizations, I'll have to check. I mean, if it comes through in the NDC code, it will be there, but usually I think it comes through as a CPT code. But so we would capture it if it's in the data, but based on work that I've done before, this is many years ago, not all immunizations are actually billed through the plans. So if I'm looking at it, I'm not going to capture everything.
Okay.
I've tried to do it and do metrics, and basically they came out very low. And it's because I don't have all the information.
Would it be in prescription, or is it its own line item somewhere?
It's usually its own line item. So under medical specialty, we don't have to go back to that slide, but if you go to medical specialty, I think you can see COVID vaccines. They got their new names, and they showed up under that.
Okay. So, because the reason why I'm asking is, do you know, is COVID vaccines at this point just sort of like, is it basically the flu shot, or is it like an annual expectation at this point? And it's just like flu and COVID every year kind of thing. Is that the idea going forward?
Well, they have a recommendation this autumn that everybody get another COVID vaccine. It's going to be formulated based on the more current viral, variation. There's sort of a combination of recommendations, I think, for people in certain age groups or with certain vulnerabilities, that they still are looking at the response to the vaccine. And for some people, they may be recommending twice a year.
Okay.
But it hasn't gotten to what I would call a steady state yet.
Okay, so that's not necessarily baked in, Emery. It's like ongoing expectation that it's like flu shots, COVID vaccines from here on out kind of thing.
Yeah, I mean it's kind of baked into our trend number. We don't make an explicit adjustment for it in the utilization. Like this is a decrease. I mean it's outweighed by all of the brand cost increases, really, honestly.
All right. Okay. Just curious. All right. Thank you.
I mean it does have an impact. We look at, especially, like on the allowed for generic, that sort of thing. I think in prior year, or not allowed, no, allowed for brand. I think last couple years, they were brand drugs, but they were $40, and so it drove down the cost. But you won't look at it until you actually dive into it specifically. But yeah, it's just baked into the trend essentially when we try adjust from year to year in this case. So the brand drug cost increases here, it's Ozempic and other GLP-1 drugs. It's just, you're seeing this huge increase because those drugs are costly per script, and it's just impacting it. Generic utilizations actually increased, but a lot of it has to do with the fact that generics, COVIDs were not generic. And then so now people aren't getting their vaccinations for COVID. And so that's driving up the increase in this case. Next slide. Specialty drugs, just kind of, the cost is increasing and usage is increasing, although it's not, I guess, as big as prior years. And overall, allowed cost increase is 4.9 for PEB in total. Taking out specialty would be 4%, so about almost 1 point increase due to specialty, but that's actually lower than it has been in prior utilization reports. So I don't know if it's good news, but specialty is becoming a little bit less of a cost driver, at least in this report. Okay, Final couple slides, top opportunities and next steps. So just kind of like, next slide, please. So I think we talked about a lot of this, mental health, social determinants of health, and diabetes. I don't know, Mary Kay, if there's anything that you want to add on, some of the things we, I think, discussed quite a bit.
Yeah, I feel like probably everybody's ready for lunch as opposed to
We may be.
additional thinking and reflection. Yeah, I do.